Good morning, friends. We are in yet another session of webinar. Webinar must have become common to all of you since the pandemic. Today we have got two different specialties. One is pediatric cardiology, and second is diabetes. And before we start, I request our president, Dr. Sujata Attar, madam, to give the presidential address.
Good morning, friends. Uh, Thank you, Dr. Anil Awad. I welcome everybody on behalf of IMA Mumbai branch for this webinar. And let me tell you, before we start this webinar, you all should be aware that from 1st to 14th, IMA headquarters has given directives for a hunger relay strike, which IMA Mumbai branch had done it on 5th of Feb at our premises, and we had got a huge response from the IMA Mumbai branch members as well as from the MSN wing, where all the medical students had gathered. And on 7, that is today, it is going to be for the women's people for the strike. And I hope everybody bring awareness among their patients regarding what is happening against no to mixopathy, so that they are aware what is happening. And before we start the program, I would like to inform you of the forthcoming program that is on 28th of Feb. We are having our Golden Jubilee annual conference at IMA Mumbai branch as well as online hybrid. Everyone who wants to register can get in contact with the IMA office. Only 90 people will be registered on physical, and those people who are going to sit from morning to evening, only those people should register for physical. Others can come on Zoom, and we will be having even online quiz after every session, and we will be giving attractive gifts for that. Thank you. Hand over the mic to Dr. Anil Awar, who is the Assistant Director IMA CGP, who will take for the further proceedings. Thank you.
Thank you, Attar madam. Without wasting any time, I will just start with the program because Dr. Naik is waiting since long. I'll just share his introduction slide. And I request our President-elect, Dr. Jitesh Mehta, to introduce Dr. Shiv Prakash Naik. Jitesh, unmute.
Good morning, everybody. It's a pleasure for me to introduce our first speaker, Dr. Shiva Prakash Krishna Naik. He is the head of the Department of Pediatric Cardiac Sciences at Sir H.N. Reliance Foundation Hospital and Research Center. He did his MBBS and MS in General Surgery from Bangalore Medical College with a gold medal. Then completed MCH from the Postgraduate Institute of Medical Education and Research, Chandigarh. Later, he received a fellowship in pediatric cardiac surgery from Royal Alexandra Hospital, Westmead, Sydney, Australia. He is a former professor of pediatric cardiac surgery at Amrita Institute, Kerala. He was also the chief pediatric and congenital heart surgeon in Seven Hills Hospital. He is a founder member of Pediatric Cardiac Society of India. He is the former president, Pediatric Cardiac Society of India, 2016 to 18. He also has several original articles published in various national and international journals. His technical skills and areas of clinical expertise include complex reconstructions, neonatal cardiac surgery, cosmetic congenital heart surgery, and valve repairs in children. Today, he will be speaking on pediatric and congenital heart surgery in the current era. Over to Dr. Shiv Prakash Naik, please.
So shall I start? Anil ji and Sujata ji and Jitesh ji, a very good morning to all of you, and hopefully it's a bright Sunday, though it looks little gloomy as of now, but Sunday is a Sunday and everybody looks forward to it. So आज मैं इतना ज़्यादा इस स्पेशलिटी के बारे में बोल के आपको बोर नहीं करता हूँ. Definitely I'll try to see to it that I'll finish within 25 to 28 minutes earlier than the stipulated time. And जो भी मैं बोलने वाला हूँ, मैं 30 years I have spent this my adult life in this specialty, so उसको हम मैं 30 minutes में cram करके बोलने के लिए काफी difficult है, लेकिन फिर भी मैं कितना simplify हो सकता है उतना simplify करके बताता हूँ आप सबको. So it is a complex heart, to be honest, for the in the entire life, as if you consider, taking care of the heart is something which is extraordinarily difficult, what you faced in your life, which are some unique moments in your life. It is something similar to that. So it is not that just a pediatric cardiac surgeon alone who is responsible for this profession. There is a host of disciplines and workforce which actually come together for taking care of one small child. And there are maybe about 10 to 15 disciplines which come around. And with the collective sense of ownership only, this program can work. And that's the reason it remains a very exclusive specialty and a very niche area in medicine. And it has got its own cup of sorrows, but this is not the moment to share with it. But what is important is that, it is an adventurous specialty if one has to really pursue. At the same time, it gives its own sense of highs whenever we achieve something extraordinarily difficult accomplishment. And it's a young specialty. It's a hardly 40-50-year-old specialty. If you see only children's heart surgery, it started in 1986, infant heart surgery. So uske हिसाब से आप देखेंगे तो it's hardly less than 50-year-old. So in that way, I just want to say a aerial view I'll give of my specialty. So what's unique about my specialty? दोस्तों मैं जैसे पहले बताया था, it's a fusion of pediatrics and cardiology and anesthesiology and general surgery. So all these things come together to form this specialty, and that's the reason success in this field definitely depends upon collective wisdom and teamwork. एक बंदा जो बोल नहीं सकता है that pediatric cardiac surgeon alone is responsible for the success of any operation. I think he बहुत छोटा हिस्सा है in this entire team, the surgeon, and it certainly mandates a sense of ownership from all disciplines. Unless and until every team player feels that he is equally responsible for taking care of the child, the success story actually doesn't happen in my specialty, which is unlike many other disciplines where I think a single man can deliver in most of the times. ये हमारी specialty ऐसे नहीं है. And that's the reason I just want to give the index dilemma for you. What happens in my profession? A fever in a child who has been operated for a congenital heart defect. And if you see in a general surgery ward, if you see in a pediatric ward, if you see in a cardiac, all these three environments, the approach will be different. But in my specialty, unfortunately, all these three specialists, or otherwise a surgeon who is or a doctor who is actually oriented with the pediatrics, with the cardiology, and with the surgical background, can only address this, because it could be urinary tract infection or it could be endocarditis. So the entire spectrum of medical challenge will face with each dilemma what we come across in the ICU. In that way, that is one of the uniqueness of the specialty. And the other challenging factors, as you see that, it's like this group which is trying to fly collectively in the sky. The other factors which are unique is that the parents, the bystanders of this patient are young. They do not have funds 4 out of 5 times. There is a requirement of multiple stage surgeries, or many interventions are required in their lifetime. And each intervention or each surgery, it consumes resources like anything, because it's a small child. And probably most important and sometimes unrecognized by the society is a very, very long and arduous training what we go through to become an independent performer as a pediatric cardiac surgeon. And that's the reason the aim should be to see to it that, we have some sort of altruism while practicing the specialty, and not just the goal of a very comfortable life for our families. And that's the reason we need to nurture this specialty from everyone, every wing of the society. This is an important point to note down, that, unless we do that, otherwise the numbers will keep on diminishing. The present generation doesn't show much interest in this specialty because of this long learning curve. So unless we have some sort of encouragement to them at the end of their training, the people will show gradually less and less interest in the specialty, which actually is completely in contravention of the actual requirement. And this is the requirement. I just want to put up the population of our globe. 1990, it was around 5 billion. Now 2080, we reached 6.6 billion. 2025, maybe another 3 years, we are going to reach 8 billion. And by 2050, we are going to reach 9 billion population. And if you see the half nine, more than 65% of the global population, it happens to be in Asia. The only country which really can handle this sort of load is Japan. It's a very, very small corner of Asia. Otherwise, the rest of Asia, which has got so much of population with such a high growth rate, birth rate, and infant mortality rate, we need to pay attention, and we need to see to it that these kind of disciplines, they flourish. And uniqueness of India is that 1 in 5% in this planet right now who is walking around is an Indian. So in that way, it just I want to use this as a surrogate to say that there are millions of children who are there yet to receive their treatment, and there are thousands of children who are being born every year, because we are not paid much attention to the population control so far. And a rough estimate, and this is a rough estimate, and this is not a really the what do you call is the accurate estimate. Maybe it's understates itself, because there are some literature which says that 1,80,000 children who require congenital heart interventions in India. And this is Dr. Anita Saxena, one of our good friend who is a faculty in All India Institute of Medical Sciences in Delhi, who wrote in an article 10 years back that an average 90,000 children, they suffer from critical cardiac lesions requiring early intervention. That could be surgery, that could be intervention, but whatever it is, that is a number. And we hardly meet halfway down to meet this requirement, even having a improved numbers of pediatric cardiologists, pediatric cardiac programs. We still see that maybe infant mortality rate may, agar aap dekhenge to 10% possibly, if you do the proper audit, may be accounted for congenital heart diseases alone. And that is the magnitude of the burden what we have got in this country. And jab मैं आया 11-12 years back to Mumbai, and only one program was there in the Mumbai city, and that was the only center for the entire 9 crore population for Maharashtra. And that was a little unusual, and that was unfortunate, because Maharashtra lagged behind at that time. But as you can see that 2010 and 2020, this is a slide which actually I put up in 2010 for a IMA lecture in Nasik. And I want to put it back again just to say that, same thing happened. In 10 years down the line, I predicted 10 centers will come up, because that was a requirement of pediatric cardiac surgery. The numbers, what were supposed to have been done. And right now we have 9 centers, if my memory serves right, in Mumbai city now. And that itself can handle, I think, a significant amount of the load. So in that way, we have traveled a long way from 1990. That's where when my training started. And 2008 when I came to Mumbai, and 2020. And in the span of 3 decades, this is what has happened now. So if you see the myths and facts of my specialty, is that these are the questions, or these are the dilemmas what the parents even now explain and express in front of me once in maybe 7 days or 10 days. हमारे बच्चा छोटा है, नहीं तो नहीं, ऑलरेडी उम्र हो गई हमको, अब क्यों सर्जरी, नहीं तो इनक्यूरेबल, क्वालिटी ऑफ लाइफ को क्या करेगा सर्जरी होने के बाद, कैन द बेबी विथस्टैंड दिस सर्जरी, वन चाइल्ड डाइड आफ्टर सिमिलर सर्जरी, और एक बार क्यों कर रहा है हमको, ऐसे ही छोड़ देंगे. So these are the questions which really keep cropping up in every of my encounter, maybe once a week or once a fortnight. And all these things aren't true anymore. We have progressed quite a bit as a part of science. And in the last 30 years, myself as a I think I was one among the few fortunate people to take up this specialty in South Asia as a exclusive job. And I myself can see that there was a time when we thought that this is one of my 25 years back, my first specialty, my first publication as a original article, in which 60 cases of a complex heart which were operated, we reported in a European journal, which was accepted as a standard results at that time, that we had 33% mortality 25 years back for this subset. And now, dosto, this is the approximate the success rates what we have got. The 33% ka jo mortality tha, this is the subset, what is called as total anomalous pulmonary venous connection, wherein the entire pink blood from the heart, which should have, from the lungs, which should have gone to the heart, Instead of going to the heart, it was going to the wrong side of the heart, or otherwise it was going to the liver. And this complex heart right now in 2020, we have got hardly 3% mortality. 97% of the times they get operated and they go home and they do not require any more reintervention for their entire lifetime. They can lead a perfectly normal life. And unfortunately, half of these children, they require surgery in the first 30 days of life. And maybe in that, maybe 25% of them in the first 25 days of life. And that is the reason, I mean, first 7 days of life. And that is the reason I want to highlight that very, very important and crucial aspect is that, the child gets diagnosed at the correct time so that we end up operating at the right time. So the present scenario is that most of the time we are handling the children in a timely fashion, and almost all children with congenital heart diseases are treated and right now in Mumbai only. There is no need for anybody to go out of Mumbai. Whether invisible scar surgery, interventions, double switch operations, Narwood surgeries, transplantations, all of them are performed in this state only. There is no need for any Maharashtrian to go outside the state to get this treatment. And the outcomes, let me say with an enormous sense of pride, whichever the center you're going right now, all the pediatric cardiac programs, we give the results which match the Western standards and possibly a shade better given the challenges what we face. The only issue is that, as I said, that we require a good infrastructure to deliver the outcome, and surgery and the art of surgery happens to be only about 10% success story, and remaining 90% happens in this infrastructure, in this manpower who participate in this sort of case. So the present challenges, what we say in a contemporary times, is that it's a finance and the prompt referral. These are the only two things which actually we are not addressed. Prompt and precise diagnosis and setting up an ideal ICU to the best extent possible. I think in South Asia, India has achieved it much ahead of others. I just want to put this slide आप सबको that जो भी symptoms है, breathlessness, precardial activity, blueness, episode of altered sensorium, anything other than lub dub sounds, anything other than that sound, और pedal pulsations मुझे feel नहीं हो रहा है, dorsalis pedis commonest उसको feel कर रहा है, and saturation below 90%. Any of these things, I just want to give a small algorithm that please let the child be seen by a pediatrician or a pediatric cardiologist. And after that, I think people like us will come into the picture if the child requires surgery. So these are some of the rough success stories what I given. Suppose we do the surgery in the neonatal stage, we have 3 to 5% risk depending upon what are the subsets we are handling. If it is infantile surgeries, operative risk is really less than 3%. And before school going age, which is the actually entire aim of my specialty, we want to send every child with a normalized heart before the child reaches the school. That is before 5 years of age. At that time, the risk is really 1 to 1.5%. Even in the centers which do not have really optimum infrastructure and optimum support, still before 5 years of age, we can address most of the children and we can send them home. So a timing of intervention, when to do, कब करना है, first 30 days में, first 7 days में, or first 1 year of life में, or when we are supposed to do, that requires a very very intimate knowledge of the natural history. मतलब ये disease को हम ऐसे ही छोड़ेंगे तो क्या होने वाला है, that natural history we need to have intimate knowledge and a very deep understanding of immediate and long term surgical results in a given center. हमारे hospital में मेरे हाथ में क्या हो रहा है करके, unless and I am conscious of that, it will be difficult for anybody to give a decision which is one size fits all sort of an indication. We can't give. Every child is going to be different. But generally, neonates will require, if they are requiring a surgery in the neonatal period, it has to be done in the first 30 days of life. Otherwise, there is a survival itself becomes a question. So 2015 से हमने शुरू किया HN hospital में, and more than 1,400 procedures we have done so far, and it's 8-bedded infrastructure, and we do about 250 surgeries a year, and number of interventions is are about 100 per year. And neonates we do quite a large number, 50, because of the uniqueness of the program and exclusiveness. And there are 7 consultants collectively in my department. It's a large department. It's a great work what we do, and any one of you can visit our center If you give me prior information, it will be a pleasure for me to show you our work, whatever the work which goes on in our hospital. And some of the salient features, what we are doing last 5 years is that the smallest child, what we have done, complex open heart surgery was 1,600 grammer. Hybrid heart surgery हम कर रहे हैं, percutaneous pulmonary wall replacement under very very able leadership of Dr. Bharat Dalvi. It goes on. It is an accredited center, and he is the proctor for this for entire South Asia. And we have certain complex heart surgeries like complete AV canals and arterial switches, even tetralogies. We carry 0% mortality. And we are noted for our work for some of the complex hearts called as double switch operations or cosmetic congenital heart surgeries. These are some of the pictures what I'm trying to show you. These are what is called as that minimal incision surgeries. These are invisible scars which are there in the back. We do quite large numbers of these children because we started this program about 21 years back, and we are one among the world leaders in doing these surgeries from the back for children, and especially in a culturally extremely conscious society like ours. And this particularly for girl children, this comes as a major boon. It's not that India does only surgery aping the West. We have got our own innovations which go on, and possibly let me tell you in the first top 5, I think if you see the innovative countries of the world, I think India stands somewhere in the top 3 itself. There are so many innovations go on, and we are cost conscious society, so that's the reason we always come up with innovations wherein we can reduce the cost of care rather than increasing, whereas the West is going the other way around. Ours, in that way, is a much more pragmatic and grounded sort of innovations we come out with. These are some of the pictures what I'm showing you of a complex hearts. And this is a arterial switch operation which is in progress. And at the end of surgery, what happens? How do they look like? And these are different set of holes what can happen inside the heart. What I put the forceps right now, what you can see is this is called as posterior muscular VST. We sometimes come across, and these are multiple holes when they happen. What should we do? These are some of our own innovations what we have published in some of the leading European and North American journals. And this photograph shows a complete AV canal in the picture. It is almost, as soon as you open the heart, instead of seeing one mitral valve, one tricuspid valve, you end up seeing one large valve, which we are supposed to create into two valves. And as I said, those 1980s and 90s, when we did our residency, the disease had a 40% operative mortality. And these days we don't have. And in HN hospital, we have got earlier, as I told you, we have got 0% mortality for these lesions. And we keep publishing our work quite a bit. We don't really come across in the mainstream media, but in our scientific forums and platforms, our center is quite well known to our work, what goes on. And some of the last year publications also, we have not been inactive. We keep doing things in our own way. And this is one very important message for all my colleagues there. To all of you, residual murmurs, surgery होने के बाद भी कभी कभी लबडब नहीं सुनाई देता है. Sometimes you end up seeing these murmurs, and lot of time if the echo has been all right, that it's of no consequence, to be honest. And they could be due to rough surfaces through which the blood is being pumped, and what we call it as residual insignificant stenosis or regurgitation. इतना हमको फिक्र नहीं करना है. So in that way, I think these residual murmurs, please remember that it might not be a serious one. It could be one of those innocuous sounds what comes in those children. Gradually, they might disappear. And ultimately, all the programs anywhere in India or anywhere in the planet, pediatric cardiac program, the ultimate king is the only guy who is sitting there like a lord after his surgery. And the entire the team, whatever I have put up, हम इसका छोटा हिस्सा है. You can see me and Dr. Bharat also, who is there in the picture. We are all small part of a large cogwheel. And it's just that all of us, we feel so much happy just to see the kids like this, lying like this. And that itself is the biggest reward what we will get in our professions. So I just want to give this message of Ganesh to you, to all of you, that Shiv Bhagwan ne isko immediately, if he had not transplanted this head, we wouldn't have had such a useful and extraordinarily affable God to all of us. And that's the reason I want to just use this as an example that early corrections usually produce useful persons for mankind. And present scenario is that we are having good outcomes not because of good surgeons, it's because of early elective surgeries, and more pediatric cardiologists have come up in the society, and more centers with the requisite ICU infrastructures have come. And probably the most important is that the present day pediatricians, hats off to them, they're extremely well informed, and they have been possibly the most proactive medical professionals right now. And exceptional infrastructure and support of manpower we have. We are very privileged to be there in HN Reliance Foundation Hospital, where infrastructure is not at all an issue. And because of this, we are able to deliver such a high quality care. And it is not, we are not alone in the planet like this. There are many other centers which, thanks to the philanthropic organizations or otherwise philanthropists who have started these hospitals, we are able to help our society to a great extent. So, to conclude, as far as I am concerned, 98% of the structure, there are still one or two diffuse pulmonary vein stenosis or otherwise single ventricle with AV valve regurgitation with ventricular dysfunction. There are some of the rarest of the rare combinations which can happen even now, wherein we just raise our hands in helplessness. But otherwise, most of the lesions which are detected, we are able to address them regardless of the weight and age, whether it's intervention or otherwise surgery. We are helping, we are making a huge difference in their quality of life and their longevity also. And I just want to add that this mini sternotomies, invisible scar surgeries, we are doing them out of complete necessity because of the ever expanding interventional field. Keyhole interventions itna popular ho gaye that surgeons has to think that they need to do they better, and they need to raise the bar. And it is just that improved perfusion and anesthesia techniques have made the open heart surgery safer. There is nothing extraordinary in pediatric cardiac surgeons achievement. I think our mentors are probably far more hardworking than me, but what has made the things better now is that science itself collectively has become better. And that's the reason I just want to say that some defects, they require immediate surgery or intervention. So please, if you have got a doubt, then there is no doubt as far as I am concerned, please contact us. We shall meet the requirements. Whether there is a resource crunch or some other challenge is there, do not worry, leave it to us. Please get in touch with us and we'll try to help. Thank you very much and have a great Sunday.
Thank you very much, Dr. Shiva. We just spoke at the end the story of Lord Shiva and Ganesha. We have Dr. Shiva to take care of the hearts of all the small children in the city of Mumbai as well as the India, all over India. Thank you very much, sir. You have explained in a nice way how pediatric cardiologists can help the children who are almost in the verge of passing away. Thank you very much. Are there any questions?
Sunday, NLG.
No, sir, but there are 273 attendees.
I know, I can see. I
Yeah.
can. They must be having a cup of coffee and relaxing and enjoying the lecture. It's okay.
Okay.
At
Thank
least,
you. Thank you
yeah,
very much,
yeah,
sir.
thank you. Thank you.
Yeah. Friends, now we move on to our second speaker, and that is Dr. Bharat Dalvi. Sir is already there online. I'll just share his introduction. We have the next speaker, Dr. Bharat Dalvi. Dr. Bharat Dalvi is a consultant in the Department of Pediatric Cardiac Sciences at Sir H.N. Reliance Foundation Hospital and Research Center. He was trained in the pediatric cardiology at Children's Hospital, Boston, the Hospital for Sick Children, Great Ormond Street, London, and Cleveland Clinic, USA. He has pioneered the technique of closing very large ASDs with using balloon assistance. He has more than 100 publications in national and international journals and more than 100 abstract presentations to his credit. Also, he has delivered more than 60 guest lectures at multiple national and international conferences. He was the editor-in-chief of Journal Annals of Pediatric Cardiology from 2008 to 2010. His areas of interest is pediatric cardiology with an expertise in echocardiographic imaging and non-surgical cardiac interventions such as ASD, VSD, and PDA, device closures, balloon pulmonary and aortic valvuloplasties, and dilatation and stenting of coarctation of aorta. Today, Dr. Bharat Dalvi will be talking to us on transcatheter interventions for congenital heart disease, scope, and limitation. Over to Dr. Bharat Dalvi.
Good morning, friends. I've been asked this morning to speak on transcatheter interventions in congenital heart disease, scope and limitations. This is a very broad-based topic, and I'm not going to restrict myself to one or two interventions. I'm just going to give you a bird's eye view of what is possible and what can be done in this part of the world. I'm not going to talk too much about theory, but tell you, share our experience with you on what we do here at the Reliance Foundation Hospital. So let me begin with this famous saying from Mark Twain. For a man with a hammer in the hand and wanting to use it, everything here looks like a nail needing hammering. This means that when you listen to a talk on interventions by an interventional cardiologist, please take it with a pinch of salt. Having said that, as a general physician, as a pediatrician, or as a family physician, what you need to know. So you need to know the scope of interventions, their limitations, their timing, which is so very crucial, as Shiva emphasized in his talk, the benefits of intervention. And your patients are going to ask you about the outcomes in terms of success, failure, complications, and most importantly, the follow-up. They are going to ask you how often do they need to follow up, what about infective endocarditis prophylaxis, medications, level of activity including sports, travel, and about marriage and pregnancy. And if you have a good idea about all these things, I think you will be able to help your patients and counsel them properly. Now, let me start by talking about the scope of transcatheter interventions. We can dilate valve stenosis, predominantly pulmonary and aortic. As far as pulmonary atresia is concerned, where there is absolutely no flow across the valve and the valve is atretic, not stenosed. It's the extreme form of stenosis, what we call as atresia, that can be perforated in the cath lab. You can deal with vascular stenosis like coarctation and branch pulmonary arteries. You can dilate the superior and the inferior vena cava stenosis. And in some cases, you can make an attempt to dilate pulmonary veins, but as was said earlier, it's a bad disease anyway. You can close defects like patent ductus, atrial septal defect. You can close muscular or perimembranous VSDs, PFOs in adults, and Fontan fenestrations. Also, you may be called to close some of the abnormal communications like pulmonary, coronary, or systemic AV fistulae, rupture sinus of Valsalva. And on the other hand, sometimes you are called to maintain the patency of the defects, like, for example, balloon atrial septostomy or PDA stenting in patients who are having duct-dependent circulation. So here, rather than closing, you need to maintain their patency from point of view of saving their life. And lastly, probably what is at the leading edge of interventions are the percutaneous valve replacements. You must have heard about TAVR, transcatheter aortic valve, but we in pediatric practice are more used to, or are more likely to deal with pulmonary valve replacements. And then once in a while, you may be called to intervene in a patient who has postoperative complication. I mean, 99% of the times it is the surgeons who bail out the cardiologists, but in 1% or maybe 1 or 2% of the times, cardiologists can bail out the surgeon. It's not really we bailing out each other. It's like we bailing out the patient from what can be considered as one of the life-threatening complications. Now, these are the limitations, and there are many more, but these are some of the conditions which cannot be treated in the cath lab. Subpulmonary stenosis, subaortic membrane, supravalvular aortic stenosis, what you see in Williams syndrome, primum and sinus venosus ASDs, subarterial VSDs, and PDAs in preterms and newborns. And I've put question marks because now there are many centers which have started dealing with these problems in the cath lab with a reasonable level of success, but then you need to have that level of experience and expertise before you venture into intervening in these very, very small and delicate babies. Timing of intervention is one of the most important things. If the condition is life-threatening, for example, if you have a severe aortic stenosis with cardiogenic shock or severe left ventricular dysfunction, I think there is no time to waste. You have to just stabilize the patient, maybe even ventilate him and get him into the cath lab and dilate the aortic valve. Sometimes it may not be life-threatening, but can result into a life-threatening complication. For example, aortic stenosis with LV dysfunction, which is not in cardiogenic shock or not with severe pulmonary edema, but somewhere in between. And if this patient were to get a diarrhea or were to develop a respiratory tract infection, believe me, this patient will get very sick very fast. So these are the patients who need to be treated urgently, as soon as possible. If you have aortic stenosis with normal left ventricular function and the patient is symptomatic, then you may need to treat him early, maybe within the next 6 weeks or maybe 3 months. And in some patients who are asymptomatic, but if you don't deal with them, there is a chance that you can adversely affect the natural history. For example, large ASD. If you don't treat, you may land up with pulmonary hypertension, Eisenmenger syndrome, or sometimes if pulmonary hypertension doesn't develop, then they may develop right ventricular dysfunction, cardiac arrhythmia, strokes, and what have you. So these are some of the ways in which you decide as to how you are going to deal with this problem. On one end of the spectrum, you have cases where you need to deal with on an emergency basis. On the other end, you have patients who can be treated electively. This is one of the most important messages I want you to take home. Mechanical problems need mechanical solutions. Most of the congenital heart diseases are mechanical. No amount of diuretics, digoxin, ACE inhibitors, ARBs, beta blockers, calcium supplements, iron supplements, they are not really going to help these patients to a great extent. I'm not saying that they have no role, but they have a very minimal role. So these patients need to be treated either surgically in the operating room or with transcatheter interventions in the cath lab. Now, before you advise or before we advise an intervention to any patient, we ask ourselves 3 questions. Is this intervention going to improve the quality of life? Is this going to prolong his life? Or is this intervention going to prevent complications, thereby making the natural history a little more difficult for the child and the family? And if the answer to these questions is in the affirmative, even if one of the questions is answered in an affirmative, I think you have every justification in intervening in this patient, may it be surgical or transcatheter. But if all 3 questions have negative answers, you can neither improve quality, nor prolong life, nor prevent complications. I think you have no business to intervene because there is very little scope for what we call as cosmetic interventions on the heart. Every intervention carries a finite risk. So it is very important that you weigh this risk with the benefit that you're going to offer. So now let me take you through a few of the interventions that we do here in our cath lab. One is the valvular pulmonary stenosis. Any age is okay, including in newborns, but we prefer that the patients are more than 2 kgs because then they can be managed easily, both pre, intra, and post-procedure. If the child is asymptomatic, we look at the transpulmonary gradient. Usually our threshold is quite low for intervening if it is more than 30 millimeters with normal RV contractility. Some people may say 40 or 50, depending upon the kind of protocols that you have set up in your unit. Important to realize that not all valves are amenable to balloon dilatation. Dysplastic valves or pulmonary stenosis with additional supravalvular PS, usually we end up with suboptimum results. And that's why it's important to counsel the families, telling them that in your child, maybe we may not have the most optimum results. And if they wish to have only one procedure, it's better that these patients are sent for surgery rather than giving them a failed balloon valvuloplasty and then a surgical intervention. In our experience, the success rate is 98 to 99%. Recurrence is quite rare and more often than not seen in patients who are intervened in the neonatal period. Really, more than recurrence, it's the residual stenosis in the subsets that I just described, the dysplastic valve and those with supra-PS. Usually they have excellent quality of life and longevity. If you give them a very severe pulmonary regurgitation, which we try and avoid these days by using a less larger balloon, and if you give them a severe PR, however, they will require pulmonary valve replacement at some time in future, maybe 20, 30, 40 years later. Once a year follow-up is usually good enough unless the right ventricle starts dilating because of pulmonary regurgitation or because there is recurrence of stenosis. And most of these patients will remain on infective endocarditis prophylaxis lifelong. So this is an example of a critical pulmonary stenosis. This is a newborn, right atrium, right ventricle. You can see this interatrial septum. Because of a huge pressure in the right atrium, it's ballooning into the left atrium. This is the short axis. This is the pulmonary valve. It is hardly opening. You can see here. And this is a very critical pulmonary stenosis. You can see it very well from this, what we call as the apical 5-chamber view. You see this. Hardly any flow across the pulmonary valve with a gradient of nearly 90 millimeters for a newborn. It's a huge gradient. So we take this patient in the cath lab. This is an angiogram in the right ventricle. You can see this doming of the valve. Then we cross the balloon with a wire, we cross the valve with a wire, take the balloon across and see that. We dilate the valve. And this is where the valve is. This is the waste on the balloon, which disappears. And you can see how beautifully the valve is opened. And you can see the right ventricular contractility. This is the right ventricle, how beautifully it squeezes immediately after opening. See how it was squeezing. A little lazy there. And you see how brisk it is here. This is because of the afterload mismatch. So immediately after dilatation, you have improvement in contractility. Valvular aortic stenosis, more or less similar. Any age, any weight, preferably not 2, but even 2.5. Because here, if you have a vascular injury in the form of a femoral artery injury, that can be quite devastating. And that's why we like little older children, maybe 3 kgs, 3.5 kgs. If the child is asymptomatic, our threshold is a little higher, because if we give an aortic regurgitation to these young children, replacing the aortic valve or repairing the aortic valve in such young children is not very easy. So we like to intervene maybe at a little later stage with a transvalvular, a peak systolic gradient of 70 or a mean gradient of 40. Usually these patients have no aortic regurg, but a trivial to mild aortic regurgitation is probably acceptable. Just like for pulmonary valve, if you have a dysplastic valve or a unicommissural valve, then the results are suboptimal. You may end up with restenosis or you may end up with severe aortic regurgitation. Here again, our results are pretty exciting, 98 to 99% success. Recurrence is the rule. If not recurrence, you'll end up with aortic regurgitation. The best thing is that acute aortic regurgitation is very well tolerated by these patients. You rarely require any emergency surgery. I have not seen one in my life requiring emergency surgery for aortic regurgitation. But important to recognize that these procedures are at their best palliative, and these patients will come back for another dilatation or they will come back for aortic valve replacement. And then you have, of course, some complications like vascular complications. You have recurrence of stenosis, you have regurgitation, and like for pulmonary stenosis, they also require infective endocarditis prophylaxis. This is an example of a newborn with a severe aortic stenosis. You see this, hardly the aortic valve is opening, and look at the squeeze. The left ventricle is hardly squeezing. We would put this ejection fraction as maybe 10 to 15%. There is no squeeze here. This patient came in cardiogenic shock, was stabilized in the ICU, ventilated, brought to the cath lab, and dilated. You see this dilatation, and what a great improvement. Within 15 days, you look at this, how beautifully the left ventricle is now contracting. So I think these procedures, although they are palliative, can sometimes be life-saving and can do a lot of good to these patients. Now let's move on to coarctations. Really, surgery is the procedure of choice in newborns. Only in those patients where there is severe LV dysfunction, multi-organ failure, or you don't have a surgeon available on site, or the baby is very small, maybe less than 1,500 or 1,200 grams, we would prefer to take them to the cath lab to dilate. It's a temporary palliation would be subsequently dealt with by the surgeons. So this is one of the newborns with severe coarctation. Again, you look at the left ventricle, barely 10 to 15% ejection fraction, and you see how tight the coarctation is. This is the aortic arch here, and you see this flow acceleration. It's just a pinpoint, and the gradient is close to 100 millimeters of mercury. In a newborn, a gradient of 100 millimeters is really a huge gradient. So we take this patient to the cath lab. You can see this angiogram. You see how tight this coarctation is? You can see here. So through this tight narrowing, we pass this guide wire, then the balloon, then we dilate, and you see how beautiful the immediate result is. But believe me, all these children, or I wouldn't say all, but say 75 to 80% of these newborns will come back with recurrence of coarctation. And then it's up to you. You can redilate with a balloon, or you can send them for surgery. Now, this is a 1400 grammer who had a very severe coarctation. And so we decided to take him to the cath lab. Despite having a normal LV function, we have used a axillary artery. You will ask me, why axillary? Why not femoral? Because axillary artery is not an end artery. And that's why even if it gets closed, you will rarely find any problem with the right upper limb. We then cross the coarct. We dilate the coarct. You can see here the waist completely disappearing. And that's the final angiogram showing beautiful flow across the coarctation. But believe me, that this patient also came back after 3 months and was operated by Dr. Shiva Prakash. So I think it's a combination and a teamwork between an interventionist and, as far as adolescents are concerned, I think primary stenting is the way to go as far as coarcts are concerned. You can see this. This is a severe coarctation here. So we are using a bare metal stent here. We are not the people who use covered stents in all patients, depending upon the indication. So this is the stent here, and you can see how beautifully now the flow is going across the coarct. This was the pressure gradient before we started under anesthesia, and this is almost zero pressure gradient between the upper and the lower limb. Now the covered stents. Covered stents we use only if you have aortic atresia or a very severe coarctation, or if you have a pseudoaneurysm like this, or if you have associated ductus, or if you have a Turner syndrome where the chances of aortic rupture are very high. I think we go ahead and use covered stent. This is one example. This is a huge pseudoaneurysm following dilatation of the coarct with a bare metal stent. This is a bare metal stent. And look at the size of this aneurysm. Very high chances of rupture and death. So we took this patient to the cath lab and put a covered stent. And you can see now most of this aneurysm is completely exteriorized, maybe a little whiff there. But this disappeared during the follow-up. And this patient is almost 8 or 9 years following a stent, still doing well. But important to remember, coarctation of aorta is not only a localized narrowing. These patients have hypertension, they have cystic medial necrosis, accelerated atherosclerosis, and some of them have intracranial aneurysms. So despite a perfectly repaired coarct, whether it is surgical or with transcatheter technique, there will continue to be a finite attrition rate because of associated complications. Let's move on to patent ductus arteriosus. These were the initial rules when we started the program. More than 6 months, more than 5 kgs, symptomatic status, and if not symptomatic, patient must have continuous murmur. At this point, it's important to emphasize, if you see a PDA on echo, but there is no continuous murmur, I don't think there is any justification in closing this PDA, because that is not going to change the natural history of the patient. There are various modalities available. You have the coils, you have the duct occluder, you have the VSD occluder, you have this perimembranous VSD occluder, or ADO2 rather than the PM VSD occluder. You have vascular plugs, so on and so forth. There are multiple ways you can close. So this is one of our patients with a small PDA, and we have used a coil here. See this coil coming and plugging the ductus. So the coil comes back into the ampulla here. And now once it is in the ampulla, we will release the other end of the coil, just a small little end. You can see that slowly coming out. And once we have delivered the coil, you can see how beautifully this duct is completely closed. So I think a coil is very inexpensive, costs around 2,000 rupees. But only small ducts with good ampulla can be closed. A ductus like this, which is moderate size for a 1-year-old child, I think it's difficult to close with a coil because it's a shallow ductus. There is not a deep ampulla. So we use what we call as duct occluders and see how beautifully we can close the ductus completely. And most of these patients will walk out of the hospital the next day. This is a 12-year, huge ductus, severe pulmonary hypertension. This is 11 or 12 millimeter ductus, but we can still close this in the cath lab using a duct occluder. This was a 16 by 14 duct occluder. What you see here is called foaming. This is a little bit of a residual shunt through the device. This will disappear within a few days, if not within a few weeks. But I have yet to see a residual shunt remaining more than 6 months ever with duct occluder. We must have closed more than 3,000-4,000 cases. But everything is not hunky-dory. You see this. This is another 3-month-old child with a long PDA. At this time, we did not have vascular plugs available, so we used the smallest duct occluder and see what happens. I mean, this is something which is a disaster. So we thought that we have closed everything, so we release, and you can see the amount of recoil, and it goes into the descending aorta. And you see here, most of the device is in the descending aorta. And this patient had to go to the operating room where the device was removed, the duct was closed, and fortunately, patient did well. So I think it's always good to have a surgeon handy. You can't say that I will be successful every time. People cannot have zero complications. Only those who don't work, only those who lie, or those who are almighty themselves can have zero complications. All of us are going to have finite complications. For all these years, such large ducts in small babies used to go to the operating room. Till such time, we got what I said, vascular plugs. So you can see what these vascular plugs are. This is a 5.2 millimeter ductus in a 7-month-old child. You can see how big this ductus is. And this patient has severe pulmonary hypertension. The pulmonary artery pressure is systemic. So this is how a vascular plug looks. It has one disc here. This is the central lobe, and there is one more disc here. So this is the aortic disc. This is the central lobe, and that's the pulmonary disc. So once it is in position, we make an angiogram to confirm everything looked good. The beauty is that this device does not protrude into the aorta nor into the pulmonary artery. And that is what makes this device so good. So now we have released this device after confirming that everything is all right. And you can see the huge pre-procedural ductus, and there is zero ductus following this is only the aorta, that's a part of the ampulla, and nothing coming into the pulmonary artery. And as I said, systemic pulmonary artery pressure, immediately after closure, it drops to around 50%. And this is after a couple of months. You can see how beautifully this device is sitting. This is the left pulmonary artery, not encroaching here. That's the aorta, not encroaching there, just sitting inside the ampulla. And that's what makes it possible for us to take care of this. But again, let me tell you, this is not going to be 100%. There are going to be cases where the devices can get embolized with such large ducts. So you need to be careful, and you need to counsel the families properly, and you must have a surgeon who is helpful and who is going to support you during the time of need. So transcatheter closure of PDA is very safe, effective, can be done at all ages, but you need to be extremely careful in neonates and young infants, also in adolescents and adults with severe pulmonary hypertension. Now let's move on to the ASD. When we started this program in 1997, these were some of the commandments which we followed. More than 15 kgs, only secondum ASD. It has to be hemodynamically significant with adequate rims. Initially, they used to be 6-7 millimeters, and there should be absence of irreversible pulmonary vascular disease. If you have Eisen-Mengerized ASD, please leave the patient alone, because closing the ASD will not only not help the patient, but can be actually counterproductive. So this is an example of how we close under general anesthesia, transesophageal echo. From the groin, we come, IVC, right atrium, ASD into the left atrium. Then we leave the sheath there. This is how the device looks. This is the left atrial disc. After the left atrial disc is delivered, you can see here we are delivering the waist and the right atrial disc. Then we confirm the position on fluoroscopy as well as on transesophageal echo. And once we are happy, we release the device. And this is how it sits beautifully. What really changed the entire perspective of ours as far as the closure of ASD is concerned is this new technique, what we call as the balloon-assisted technique. We became more confident of closing large ASDs, and not only that, but we could close ASDs very predictably. That's the most important thing. When we went in the cath lab, we were 99.9% sure that we will be able to close this patient technically. And this is how balloon-assisted technique looks. This is a balloon in the right atrium. That is the device. This is a 40 millimeter device closing a 36 millimeter defect. This is the left atrial disc here coming from the right superior pulmonary vein. This balloon prevents the herniation of this disc across the defect into the right atrium. And that's the beauty of this technique. Then we deliver the waist and the right atrial disc because we have all the time in the world now. Once both the discs are in position, we start deflating the balloon. Balloon is completely deflated, and see how beautifully this 40 millimeter amplarger septal occluder is sitting there. Once we are happy with the position, remove the balloon, remove the wire. Then we do what is called as the Minnesota wiggle. Just push and pull the device to confirm that it is quite stable. And once we are happy with the stability, we release it. And this is how a 40 millimeter amplarger septal occluder looks, closing a 36 millimeter defect in an 18-year-old child or an adolescent. So this is how we improved over last 23 years. Weight became less of a criteria. If the patient needs it, we can close this even at the age of maybe the weight of 5 or 6 kgs. We close very large ASDs, fenestrated ASDs, multiple ASDs, and what have you. So this is an example of two ASDs which are far away from each other and will not be able to close them with one single device. So what we do actually, instead of putting one umbrella, we put two umbrellas. And you can see here, one wire going through this hole, one wire is going through this hole. We will put one delivery sheath through this, and we will put another delivery sheath through this hole. So once that is done, then we start delivering the devices. And you can see that the first device will be here, which is closing the hole, which is lower down. This is the inferior vena cava here. Superior vena cava is here. So once this is closed, you can see that there is another big hole here. So we'll have the other umbrella coming there, and then we will deliver the other umbrella. Once we are happy with the position of these devices, we will release this umbrella. It has become flat now. Now we will release this umbrella, which will also become flat. And this is how the two devices close to ASDs. So this is a huge aneurysm, and there are multiple defects, maybe 5, 6, 7. This is the left atrium, the right atrium, and that's the aneurysm. You can see that. This is in various views. So we decided to use what we call as the cribriform amplarger septal occluder, and all these holes are beautifully closed. Maybe a little bit of trivial leak may be there from one of the ends, but it is hemodynamically insignificant. However, again, there are limitations. This is a 34 millimeter device closing a 32 millimeter ASD. After deployment, got embolized. We retrieved it percutaneously and closed the defect with a 36 millimeters. Some of them we may not be able to retrieve, and we'll go to the operating room for removal of the device. Perimembranous VSD closure is, again, weight more than 10 kg, hemodynamically significant shunt. VSD is usually less than 13 or 14 millimeters, but you can at the most go up to 16, and separation should be more than 3 millimeters, not 2. Initially, this was closed using what we call as asymmetric amplarger perimembranous VSD occluder, but this device caused increased incidence of complete heart block, so went out of vogue. Now there are some of the VSDs, there are some of the other devices like ADO2, which is used to close this. And we have been also using what we call as amplarger duct occluder, as is seen in this case, which closes the perimembranous VSD. But in our practice, we are really concerned about closing perimembranous VSDs because it's a very uniquely positioned defect, which is very close to the tricuspid valve, aortic valve, and the His bundle. So you may end up with tricuspid valve injury, aortic valve injury, complete heart block, or left bundle branch block, which can cause dyssynchrony and a cardiomyopathy-like picture. The problem is that you may convert a relatively benign problem into a much malignant problem. So our threshold for closing perimembranous VSD is very high, but I'm talking about only our group. I'm not talking about anybody else. There are many people in the country, many people in the city, in the state, who still close and close it maybe reasonably safely and effectively. Now, these are some of the neonatal interventions. Before I conclude, this is pulmonary atresia, which is perforated with a guide wire. We take a very small device, a very small balloon to initially dilate, and then with the bigger balloon. So you can see what happens. A complete atresia, nothing going through. We have been able to create a wonderful antegrade flow. You can see how well this flow is now. And this patient went on to have an excellent quality of life. This is another neonate weighing around 2.5 or 2.6 kg, has a pulmonary atresia. We perforated the valve, and this is how we stent the ductus so that these duct-dependent circulations can be palliated. This is the stent in the patent ductus arteriosus, and you can see how beautifully it looks. So instead of a BT shunt, we have a stent doing the same function. This is instead of stenting the patent ductus arteriosus, sometimes you may need to stent the right ventricular outflow tract. This is a tetralogy of fallow with pulmonary atresia. Again, we have perforated the atretic valve here. Then we have gone with a small balloon initially, then with a bigger balloon here. You can see, so the atretic valve is completely taken care of. Then you go with a little larger balloon here. And in order that this tissue doesn't collapse, we have stented it. This is the stent here in the right ventricular outflow tract. This is the stent which is deployed, and that's the final angiogram. So that's the final angiogram. Sometimes you may be called to do some very unusual interventions. This is an AP window. Aorticopulmonary windows are usually large and are in the domain of the surgeons. Occasionally in the cath lab, if they are small and restrictive, complete closure of the AP window. This is a coronary AV fistula. I'll take not more than 2 minutes. So this is a coronary fistula opening into the right atrium. This is how it looks. In the other view is a huge one. This is a coronary sinus opening into the right atrium, and we have plugged it using a duct occluder. This is immediately on table, and this is after 2 years. You can see that that residual shunt has completely disappeared. There is no shunt now. And look at the way these coronary artery branches are getting lit up once the fistula is completely closed and there is no steam. This is really a much elderly person, but a huge pulmonary fistula. This is congenital, and we have closed it pretty effectively using a duct occluder here with almost no residual shunt. This is a post-operative patient with a blocked BT shunt, and this is how we open up with a balloon. So this is one of the cases where we can help the surgeons, and this is how it's opened up BT shunt. And I think I'll skip this, and I'll take you, okay, I'll show you in half a minute. This is a large VSD. This is a hybrid procedure, truly a teamwork between a cardiologist and a surgeon. This is done in the operating room without there being any fluoroscopy. It is only under echo. This is, see how big this defect is. This is a 4 kg child, and this is an 8 or a 9 millimeter defect. So this is the surgeon who is trying to protrude or poke into the right ventricular free wall. This is where he's going to puncture the right ventricular free wall. He has already punctured the wall. This is all done by the surgeon. And then the guide wire is passed, and then the cardiologist takes over, and then we pass the sheath. And this is all done on a beating heart without cardiopulmonary bypass. See how well you can monitor these cases. This is the left ventricular disc, right ventricular disc, and the VSD is completely closed. The beauty is no cardiopulmonary bypass. These patients are off ventilator within 6 to 8 hours and go home within 36 to 48 hours. So that's the beauty of these hybrid procedures, which are done either in the operating room or they can be done in the cath lab. And more recently at Reliance Foundation, we have been doing percutaneous pulmonary valves. This is one such case. We have already done 6 cases where this is artificial pulmonary valve put percutaneously without opening the chest, because this patient has undergone 3 previous open heart surgeries. So it's dangerous to send him for a 4th one. And we got an excellent result. We are one of the only centers in the country who has been licensed to do these cases independently on our own. So, ladies and gentlemen, in conclusion, transcatheter interventions for a variety of congenital heart diseases are here to stay. They are reasonably safe and effective, provided you choose your patients correctly. They will significantly reduce morbidity when compared to surgery, but only maybe 10% of all the patients can be offered this modality of intervention. 90% of pediatric cases will still go for surgical repair. What it requires is a meticulous planning and execution. More importantly, the audit of what you're doing, and that is how we went away from doing VSD closures in the cath lab, because we thought that it was not worth taking that kind of a risk, and doing a procedure which is not as predictable as surgery. And last but not the least, as was emphasized by Shiva also in his earlier talk, it's all about team effort. Thanks for your patient hearing, ladies and gentlemen.
Thank you very much, Dr. Bharat Dalvi sir. It was an excellent presentation. As you rightly said, though this is a very recent and very good option for a surgical intervention, the number of cases are still less, but I'm sure with the experts like you, the scope of transcatheter intervention is much more in future. Thank you very much. And there are no questions I can see in the question box again. Um, Maybe both the speakers have done their job at their best. And thank you again. Now we'll move forward for the next lecture again in pediatrics, but this time it's not the heart; it is the hematology. And to talk about the hematological aspects of children, we have Dr. Ruchira Mishra. And to introduce Dr. Ruchira Mishra, I request our President-elect, Dr. Jitesh Mehta.
Thank you, Dr. Anil. Friends, Dr. Ruchira Mishra is a consultant in the Department of Pediatric Hemato-Oncology and BMP at SRCC Children's Hospital. She did an MBBS from Kanpur University with a distinction in biochemistry. She did DCH from LLRM Medical College, Meerut, followed by a DNB in pediatrics from Bombay Hospital. She then pursued pediatric hemato-oncology and bone marrow transplant training in Australia and worked at Brisbane, Melbourne, and Sydney. She was further trained at the Children's Hospital at Westmead, Sydney, Australia, in pediatric oncology and earned a specialization in BMT. On her return to India in 2011, she was involved in setting up the pediatric transplant program at Medanta, the Medicity Hospital, Gurgaon, and Rainbow Children's Hospital, New Delhi. She has authored a number of articles in peer-reviewed journals and textbooks and has been a faculty at numerous conferences. She has a special interest in pediatric bone marrow transplants for thalassemia and relapsed malignancies. Today, Dr. Ruchira Mishra will be talking on hematological disorders in pediatrics. Over to Dr. Ruchira, please. Thank you.
Good morning, everyone. Thank you so much for allowing me to come on stage today to deliver this talk on hematological disorders in pediatrics. Being a pediatric hematologist, we often get referrals for different kinds of anemias, especially from the doctors who are seeing them at the peripheral centers. And often we find that they've already made a diagnosis about it, or they have some other concerns with which they are referring these patients to us. So just want to go through the basics of hematology with you and discuss a little bit about bone marrow transplants for our patients that we can do and offer them cure for these patients. So what actually is anemia? We all know that So we all know whenever your hemoglobin level is too low to meet your cellular demands, the oxygen demands of your body is what we classify as anemia. Anemia can be either it can be physiological anemia, or it can be anemia that needs attention and needs to get some kind of treatment to be done for it. So yeah. And the levels of anemia are very different for different age groups that we see. And the same hemoglobin cutoff cannot be used as a generalization for all age groups. So whenever we use a definition for anemia, we say that it's the HB level less than 2 standard deviations below the mean age, for gender, race, and your developmental state. So that becomes your cutoff for anemia. And how is the blood formed in our body? We know that it starts off when the blood formation starts in the yolk sac of the embryo, gradually shifts to the fetal liver, and then shifts to the bone marrow, where it continues production even during the adult period as well. So, and the hemoglobin has constituted of different proteins, and the proteins will actually shift the the embryonic hemoglobin is made up of different chains, the fetal hemoglobin made up of alpha and delta chains, and then the adult hemoglobin comprises of the alpha and the beta chains as well. So this shift actually transition happens, and you will see a shift in the level of hemoglobin for all our patients based on where you are catching them when they are delivered or even during the neonatal period. Once they're born, also then the hemoglobin levels depend on what gestation they have been delivered or born, and that may your hemoglobin may be different for different gestational periods. So if you have a real very low birth weight or preterm baby, then your hemoglobin cutoff, the normal hemoglobin sits around 13.4. But if you have somebody who's in a higher, like a normal birth weight, then for that child the normal hemoglobin should range between 16 to 18 grams per deciliter. There are very different factors that affect the baseline hemoglobin in any child. These could be age, gender, race, as we said, the sexual maturation. So around puberty, the hemoglobin levels will change for different for the children. The altitude at which the child resides, and also hereditary factors play a very important role in defining that what is the baseline hemoglobin of the child. So how do you actually define anemia, and how do you assess the severity of this anemia? WHO has given a definition to assess the severity of anemia as and defines it as any hemoglobin for a child who is between 6 months to 5 years of age as being less than 11, but it can be further classified into mild, moderate, and severe. And we say severe anemia is anything that's less than 7. For a child who is between 5 to 11, the anemia defined as any hemoglobin less than 11.5, but again, to call it severe anemia, we say it should be less than 7. And as you grow older, for an adolescent kid, the classification changes to hemoglobin levels being less than 12 to classify it as anemia. But severe anemia again will be classified as something that is less than 7. So before we talk about anemia, there is an entity called as physiological anemia of infancy. And we all know that because of these shifts in the hemoglobin pattern, so you shifting from a fetal hemoglobin to an adult hemoglobin type, you do see a physiological nadir that normally occurs at around 2 months of age. This is physiological, it will recover on its own. You really don't need to intervene in this period except to make sure that the child is healthy and active. However, in preemies and in low birth weight babies and in mothers who are already anemic from before, because we all know that kids are parasites and they will take the hemoglobin and iron stores from the mother, you may actually develop this physiological nadir slightly earlier as well. So you have to be aware of this condition. You have to be aware as to what are the reasons why this is happening, and then we can we just have to support the child when by the time the child recovers. However, if at any stage their hemoglobin falls down to less than 7, then they should be supported and they should be offered a blood transfusion and look at the reason why they're developing this anemia, and what we can do about removing the precipitating factors for these patients. So as I said, we have to the reason why these kids develop the anemia is because they have a decreased red blood cell mass at birth. They have if they're in hospital, they have more iatrogenic losses from the lab draws. There's a shorter lifespan of the RBCs. There's inadequate erythropoietin production happening. Plus, the body is very rapidly growing. So these become the reasons why these kids will actually develop physiological anemia, and the preterms will develop it slightly earlier as well. However, when you come to the pediatric population and you see anemia, you can actually classify it depending on the size of the RBCs that you see. So you can classify it microcytic or normocytic, or if the size is bigger of the RBCs, then you classify it as macrocytic anemia. Microcytic anemia is the commonest form of anemia that we normally see, and nutritional anemia is again the commonest reason for developing a microcytic hypochromic anemia in these patients. The common causes that you will find for a microcytic hypochromic anemia are iron deficiency, thalassemia. If there's some acute inflammation happening in the child, develops anemia. If there's some unstable hemoglobinopathies, and in rare cases, lead poisoning may also be a cause for microhypoanemia. Whereas normocytic anemia is generally seen when you have hereditary spherocytosis or a G6PD deficiency, or if you have transient erythroblastopenia of childhood or congenital syndromes like Diamond-Blackfan anemia. And macrocytic anemia, we've normally seen that it happens with a B12 and folate deficiency being the commonest reason for it. But Fanconi's anemia, aplastic anemias, or sometimes anemias that are associated with Down's syndrome or hypothyroidism can also be macrocytic anemias as well. You can also classify anemias by the mechanism by which they are developing. So either there is a decreased production like you see with nutritional anemias or thalassemias, or if there is an increased destruction that you see with like a G6PD or a hemolytic anemia that happens there. Or if you have hemangiomas, so look at the child very well to make sure that there are no hemangiomas being missed in these patients. So make sure that you know the reason why you have a child who's developing anemia. In case you really can't make a differentiation, we'll just go through how to make a differentiation between decreased production and increased destruction. But if you have any doubts, then a bone marrow is often the investigation of choice that we want to do to make sure that we're not missing something where there is a decreased production happening. There is another kind of anemia which is hemorrhagic anemia, which generally happens in the antepartum period, where you have an abruption or a placenta previa happening, and that's where the blood loss happens. Also, sometimes in twin to twin transfusion syndromes, you can see that one child is anemic whereas the other child has plethora. And usually the difference in hemoglobin would be about more than 5 grams per deciliter. The anemic twin tends to develop congestive heart failure, whereas hyperviscosity is seen in the plethoric twin in these patients. So that is there. Um, I will just go through this. So we have a rule of thumb to say what is the lower level of normal for hemoglobin concentration when you're looking at a child in the OPD. Remember that 11 plus 0.1 into the age in years is the lower limit for this hemoglobin for this child. 0.3 grams, that would be normal. But if I have a 7-year-old female with the same hemoglobin level, this would be anemia for this child. So that's the way you can remember this. It's called the 11 plus 0.1 rule. And also you can look at the MCV. So the MCV, the lower limit of normal, is the 70 plus the year rule. So again, 70 plus the age in years, that's the lower limit of normal for MCV. So an MCV of 73 in a 2-year-old child is absolutely normal. But an MCV of 73 in a 7-year-old child is definitely microcytic anemia in these patients. So this is a very easy rule to remember, and you can use it in your OPD practices very well. Now, once you find that the child is anemic, the next thing you need to look at is the reticulocyte count that the child has, or the reticulocyte count production index, as we call it. This helps to differentiate whether there is a problem in the production or there is an increased destruction happening. If your reticulocyte count or your corrected reticulocyte count is on the higher side, then this is an indication that there is an increased destruction happening. However, if your reticulocyte count per se is low, then that means that the blood is not forming adequately and there is a the problem is in the production index is calculated by reticulocyte count into 0.5 into the hemoglobin that is observed upon what would be the normal hemoglobin for age for that child at that time. The other test that you can look for to differentiate between these is to ask for a peripheral smear. For any hematologist, asking for a peripheral smear is one of the most important tests because that gives us a lot of information as to what kind of anemia we are dealing with. If you're looking at spherocytes on that peripheral smear, you know that this is hereditary spherocytosis or maybe an ABO incompatibility that you're seeing. Eleptocytes on that peripheral smear, you know that this is hereditary spherocytosis or maybe an ABO incompatibility that you're seeing. Eleptocytes or pycnocytes suggesting that there's a G6PD deficiency happening. The RBC indices are the next thing to look at, because they give you a very clear idea whether this is microcytic, normocytic, or that are present to define these. The anemia is a reticulocyte count, and as I said, we can easily predict which is whether there's a bone marrow production problem or there is a destruction problem in these patients. And then the last one that we have is a Coombs test. So once you have anemia and an acute onset anemia, ask for a direct Coombs test, and this will tell you whether there is some autoimmune hemolysis occurring in these patients or not. There's some other diagnostic studies which may help, and these are the blood type on the RH when you're looking at isoimmune hemolysis, especially in neonates, where there may be a blood group mismatch between the mother PET test, which looks at maternal blood and fetal-maternal hemorrhages. Ask for a chest X-ray if you're looking at pulmonary hemorrhage. The torch titers to look at congenital infections, and DIC panel looking for consumptive coagulopathies. An ultrasound if you feel that there may be some occult hemorrhage present anywhere. And then if you can't find all these, then we ask for some enzyme studies or membrane studies to look for RBC defects or intrinsic RBC function defects. A bone marrow aspiration helps to define congenital hypoplastic or aplastic anemia. And then we ask for a peripheral smear of these patients. So every time we see anemia, the first thing to ask is a peripheral smear. And we also ask for a peripheral smear of these patients because few weeks of pregnancy. There was pallor present, the spleen was 4 centimeters, and the liver was enlarged with a span of 8 centimeters. When we asked for the blood group, the blood tests, so we saw that the hemoglobin was only 4.5, TLC was normal, so 11,000, and the platelets were also adequate at about 1.8 lakhs. An HB electrophoresis was done, which showed that the HbF was 25%. I would just like to make a comment over here that HbF level, so electrophoresis done before 6 months of age, is really not very reliable because there is still this transition happening from fetal hemoglobin to adult hemoglobin, and fetal hemoglobin has a lot of HbF in it. So this is doing an electrophoresis before 6 months. You should always plan to repeat it after 6 months of age if you're thinking of some kind of a hereditary persistence of fetal hemoglobin, or you're looking at thalassemia syndromes. Now, when we asked for the peripheral smear of these patients, so every time we see anemia, the first thing to ask is a peripheral smear. And we saw these classical bodies that you can see there. Just because I can't unmute and ask others to say, this was a case that was congenital malaria. And the mother's history of fever in the last few weeks of pregnancy was a guide to be looking for infections in these patients. And that is how we could pick up the anemia in this child. The case 2 was an 18 months old child who presented with pallor and fatigue, had also been eating dirt. He's known to be a very picky eater, but on examination was hemodynamically stable, did not have hepatosplenomegaly, had a low hemoglobin of 4.6, MCV was also low at 55, and the platelet count was high at 520. We asked for a reticulocyte count, it was 2.1, which is low for that hemoglobin. And we also asked for iron studies. So his total iron binding capacity was high at 510, and his ferritin was very low at 3. Further history taking revealed that he was predominantly milk fed. Now, without asking for any other investigations, we know that this child is going to be a micro hypo chromic anemia. He also has a lot of anisopoikilocytosis. That means there are a lot of cells of different sizes present in his smear. And when you compare it from the normal smear, which is you can see on the left hand side of the screen, you know that this is the cells are kind of ring shaped that you see there. They are pale in color as compared to the normal side. So that's microcytic and hypochromic for you. And they are smaller in sizes compared to the normal RBCs that you're seeing on the left hand side. So this was a clear case of iron deficiency anemia, the commonest cause of nutritional anemia that we see in our day-to-day practice. Why is iron important for us? Because iron is used to make the red blood cells in our body. Once the iron gets absorbed from the intestines, it is then taken up into the liver, and from the liver it goes into the bone marrow, where it is utilized for the production of the RBCs. So almost about 65% of the total body iron will be used for making your red blood cells. And if you're deficient in iron, the first thing that gets affected is your blood levels. So what is the treatment for iron deficiency anemia? This is something that can be advised as each and every at the grassroots levels itself. We want to decrease your milk intake because we know that the milk and the kind of decreases the absorption of iron. We want to promote iron rich foods, and you have a huge list of iron rich foods that we have. At the same time, you also want to evaluate for blood loss. So please ask for any blood loss that the child may be having, either per rectal or in the urine as well. And treat for worm infestations as well, because that may be a reason for chronic blood loss in these patients. If the child is hemodynamically stable, we actually don't need to transfuse these patients, but we need to start iron therapy for these patients, and that would be giving them ferrous sulfate at around 4 to 6 milligrams per kg of elemental iron per day. There are hundreds of preparations available in the market. Please make sure that you look at the list to see how much of elemental iron is being given to the child, and you base your dose based on this 4 to 6 milligrams per kg of elemental iron per day. We generally advise giving it on an empty stomach to promote absorption, not giving it with milk or tea because that hinders your absorption. Or if you really want to give it, you give it with some iron, vitamin C, or some citrus fruits, so some juices to be given with the iron intake to promote absorption for these patients. Generally, pediatrics does not use IV iron unless you're actually suspecting malabsorption. We know that the bioavailability of oral iron is very good, and we should be able to get away with just giving oral iron therapy. Also, what you need to do is do a reticulocyte count and a hemoglobin level about 2 weeks after the iron therapy has been started, because you should see a jump by at least 1 gram percent in the hemoglobin if they've been giving it diligently. And the reticulocyte count should increase because that tells you that the bone marrow is now compensating and functioning much better in these patients. Um, Once the CBC normalizes, remember that you have to treat for at least 3 months after the CBC normalizes to replete the iron stores in these patients. Most of the children will respond to this iron therapy, but we know that some of them may still be refractory to the oral iron therapy. And the first and the most common reason for this is non-compliance. So you actually need to go back and look at the medication, sometimes even call for the number of empty bottles that they may have to check whether there is non-compliance present in any case. Rarely in children, we will have malabsorption, so that may be celiac disease or some other genetic mutations that may be there. And very, very rarely would we have some refractory iron deficient anemia patients, which will need IV iron therapy. The third case that we have is a 7-month-old boy who presented with progressive pallor and lethargy for the last 2 months. He had again been exclusively breastfed till date. There was a slight prominence on the forehead. There was severe pallor. There was mild icterus. Now, whenever you have icterus present in a child, this generally tells you that there is some amount of hemolysis happening in these patients. So the next exam was to look at his abdomen, and we found that his liver was 4 centimeters below the costal margin with a span of about 10 centimeters, and there was also splenomegaly present. His hemoglobin was low, his white cell count was on the high on the side, it was 25,000, but neutrophils 15%, lymphos 85%, platelets were 4 lakhs. And interestingly, the hematologist who had looked at this had said that there were some nucleated RBCs that they could see. The red blood cell indices were suggestive of a microcytic hypochromic anemia, and there's something called a red cell distribution index or red cell distribution width, RDWs, which was 17 in this patient. So what is the importance of this thing? When you look at the peripheral smear, you see that this is a micro hypo picture, but the cells look almost the same size itself. Now, since the child was more than 6 months of age, we asked for an HB electrophoresis, and here we see that the HbF is very high in these patients, suggesting that this is the case of thalassemia in our patients. What is thalassemia? So thalassemia is either a decreased production of the alpha globulins or the beta globulin chains in the body. And because of this imbalance, it creates anemia. Also, your bone marrow expansion occurs and there is extramedullary hematopoiesis happening. The brain still recognizes it as being anemic, and therefore it tries to increase the intestinal iron absorption to cater to this low hemoglobin requirement. And there is a lot, because of this abnormal synthesis or the abnormal shape of these cells, they get destroyed very easily in the spleen, and that leads to your anemia developing in these patients. It is an inherited disorder caused by a genetic mutation that happens. And you find that if you have two parents who have thalassemia minor, then these patients may have a 25% chance of developing a child who's thalassemia major. Remember that thalassemia minor is not a disease, it is just a clinical condition. The parent or the child who's a thalassemia minor remains completely asymptomatic and does not develop anemia, but may have hemoglobins that are in the low normal range. So hemoglobins in our thalassemia minor patients vary between 9 to 10 grams per deciliter, whereas a thalassemia major patient will drop his hemoglobin to 4, 6, or even lesser than that in case you do not give them blood transfusions. 25% of children who have parents who are thalassemia minor will still be normal, completely normal, because they have inherited the normal genes from these patients. What is the treatment for thalassemia major patients? The treatment for thalassemia major is either you constantly support them with blood transfusions, but this leads to iron overload and other morbidities in our patients, or else you offer them a bone marrow transplant. So, bone marrow transplant is a curative option for these patients. Alpha thalassemia, on the other hand, is a defect of the alpha chains in your body. You can normally you have four alpha chains in your body, two chains being inherited from each parent. If you have three chains, so there's one gene defect happening, then you have a silent carrier. If you have one deficient but one normal inheritance, so you have alpha alpha but negative on minus minus, that is still called a thal trait. And in these patients also there will be no defect present, so there will be no anemia in these patients. Excuse me, just give me 1 minute. Sorry about that. The patients who have alpha thalassemia major generally have a very severe phenotype, and then they are generally we see a fetal loss happening in these patients, or they have severe microcytic hemolytic anemias in these patients. So for those patients, we actually need to offer them bone marrow transplants or even start in utero transfusions in these patients. But beta thalassemia patients, so if you have a beta thal major patient, then you support them either with lifelong transfusions, in some cases offer a splenectomy, but in most cases the only curative option that you have at this stage is to offer them a bone marrow transplant. Now, thalassemia major or thalassemia traits are often differentiated or difficult to differentiate from iron deficiency anemias. And there are a few indices that you can use to calculate these. The Mensa index, the red cell distribution width, the red cell distribution width index are also good examples that you can use. And these can easily be calculated from the MCV and the lab reports that come to you with the CBC in these patients. So a Mensa index is your MCV divided by your RBC count, and anything that's less than 14 suggests that. Anything that's more than 14 suggests an iron deficiency anemia. Your red cell distribution width is your MCV uh, um, MCV divided by the red cell distribution width, which comes as a number on the CBC, divided by the RPC count, and anything that's more than 220 suggests an iron deficiency anemia. So as we said, the option for treatment for our patients is to offer them a stem cell transplant. If you offer stem cell transplants to patients who are younger, you have a very good response. Even in India, we have publications which say that if you offer it to a low risk patient, then you have 90 to 95% survival chances. With the transplant, we actually take off immunosuppression by the end of the first year itself. So at the end of the first year, we are offering a child who's absolutely normal, not on any medications lifelong, and has the potential to live a normal life like his other siblings can. If you do a transplant for a class 2 thalassemia, the chances of survival are about 70 to 75%. And if you offer transplant for a class 3, that's where the problems and complications are more. So an earlier referral and an earlier transplant definitely benefits your patients in these patients. We have now move on to the next case. This was a 12-year-old female child who had pallor for last 3 months, fatigability for a month, puffiness and edema of her feet for the last 15 days. There was no bleeding, there was no weight loss, there was no jaundice, no history of blood transfusions. However, on examination, she had hyperpigmented knuckles, no liver or spleen present. Now, hyperpigmented knuckles is a sign that this patient could have some kind of a vitamin deficiency. When you look at her smear, you find that the MCV was high at 800, MCH was a bit high, the RDW was 25, which was also high. Her platelets were on the lower side of this thing, was 1 lakh, and there was macrocytosis present in these patients. Now, reticulocyte count was low, but because there was macrocytosis present, we asked for a peripheral smear. We saw an LDH also. We were asked for an LDH which was high. Now, LDH generally tells you that there's just a rapid cell turnover. It's a very non-specific test for us. But the bone marrow was very, very suggestive. This was a megaloblastic anemia. Now, a megaloblastic anemia, as he said, the commonest causes for these patients are B12 and folate deficiency. So the moment we got our B12 and folate levels, we found that that was the reason why we had this megaloblastic anemia, and giving them the replacement therapy corrected the anemia. Now, the reason I wanted to pick this up was that we'd also noticed that the platelet count was low in these patients. So the moment this anemia kind of progresses, it just decreases the other cell lines as well in these patients. So you just having just let me say that your risk of your this thing should be higher if you have you should look if you have macrocytosis in any patient, and you should not think that if there are 2 cell lines decreased, then this cannot be a B12 deficiency. You could still have a B12 deficiency with pancytopenia present. I will move on to the next case. This is a 3.5-month-old child, but a product of a consanguineous marriage. And this alerts us because consanguineous marriages lead to heritable diseases, was febrile, was tachypnic, had severe pallor, also had CREPS, had massive hepatosplenomegaly. And when you look at the picture, we could see that there was anemia present, but we also had thrombocytopenia, and we had our TLC, which was 16,600, with a lot of our nucleated RBCs present, but also the premature forms of the lymphocytes present. So your promyelocytes and metamyelocytes were also present on the peripheral smear. When you look at the X-ray, it is classical for this case. You can see that this is a case of osteopetrosis. Classical patient, tachypnea and pancytopenia, consanguineous marriage. Always ask for an X-ray in these patients, and hepatosplenomegaly. The answer for osteopetrosis is a bone marrow transplant if it is picked up early, because that is the only way that you will be able to help the child. If the damage is more, then these children do not do well, and the transplant also may not actually be successful in these patients. My next case is a 11-year-old child with fever, pallor, subconjunctival bleeds present, had hepatosplenomegaly, and also had a high white cell count and presentation of 33,000. Also on this smear, you could see blasts present. Now, a lot of labs do not report blasts as blasts. What they will say is atypical lymphocytes seen. So your index for suspicion goes up whenever you see this report saying immature lymphocytes or abnormal lymphocytes seen, atypical lymphocytes seen. The child also had abnormal PT and APT present. Now, when you can see blasts, we know we are dealing with a leukemia, but when you have an abnormal PT, APT, or you have a coagulopathy present, then this is an indication that this is leukemia and AML, and this is an acute promyelocytic leukemia, APML. APMLs have a very sinister presentation. They are very sick when they present. However, this is one of the AMLs that does very well and responds very well to therapy. So in our malignancies, we subclassify them as either being myeloid origin or lymphocyte origin. So AMLs are myeloid origin, whereas your ALLs are the lymphocyte origin of these patients. We see a lot of normoblasts when we look at the bone marrow, and that's the classical picture of normoblasts that you can see over there. Another picture of a normoblast, you can see that they are larger cells with a very big nucleoli present. The myeloblasts have more dense nuclei present, and sometimes what you can see is ore rods present in these patients. The commonest presentation for hematological malignancies is night sweats, fever, common symptoms which you will find with a lot of other patients, malaise. But if you have swollen lymph nodes, then please ask for a lymph node biopsy in these patients. Don't ask for an FNAC for our patients, because we often get false negative results. A few of our lymphomas may actually present with just itching, a lot of excessive itching in these patients, but some, like our case, may present with bleeding, bruising, or even bone and abdominal pain because of the hepatosplenomegaly or the extramedullary hematopoiesis. The tests that we want to, in addition to your CBC and a blood film, is to ask for a biopsy of the lymph node and ask for a bone marrow examination, because the bone marrow is the site for production of all our blood cells, and that is the way you can actually categorize your patients into the different kinds of leukemias that they may have. We ask for cytogenetics because that is a very important factor for prognosis of our patients and to risk stratify them and offer them the right therapy. In addition to the immunophenotyping, which has become a very integral part of any leukemia management in our patients. My last case, I will take this as the last case because we're running out of time. You have CBC, which was low, 4.5, white cell count, which was high, and again there were atypical lymphocytes present. There was a LDH high at 700, again a marker of rapid cell turnover. But the other markers, in terms of trying to guide you whether this could be a leukemia or not, is uric acid, which was again high, potassium, which was high, calcium, which was low, and phosphate, which was high. So bone marrow was done and an X-ray was done, and this was an ALL that we were dealing with, an acute lymphoblastic leukemia. ALLs tend to develop tumor lysis syndrome very quickly. So the cell death leads to kidney damage, and that can lead to tumor lysis syndrome as well. How do you treat them? You need to know what disease you are dealing with to be able to treat them well. And treatment can generally be chemotherapy alone in most of the leukemias and the lymphomas in our pediatric age group. Most of them will need some amount of steroid therapy, and that is why we have been trying to push to say that every time you think about giving steroid to your patient, please do a bone marrow to make sure you're not having a leukemia lurking somewhere. Some of our patients may need radiotherapy, and only in the relapse settings in our pediatric population for leukemias, lymphomas, would we look at offering them a hematopoietic stem cell transplant. The treatment generally is in different phases. So for classical ALL, we would have an induction therapy, then a consolidation therapy, and then a maintenance program to happen. But the treatment is of a longer duration in these patients as well. Survivals have actually improved improved not because we have got better drugs at treating them, but because we have got better supportive care to offer to these patients. And what we really need from all the pediatricians and the general practitioners is to offer them good supportive care. If you have good supportive care to offer, your survival rates will actually improve. We will be able to send our children back to their residences knowing that there is good supportive care available to them locally, and only in the case that they need the chemotherapy do they need to come to us and get the chemotherapy and then be able to go back to them. All cases of anemia are not may not just be hematological diseases. So we have a 5-year-old child with jaundice, history of a similar illness 1 year back, not transfused, but there's a history of a neurological illness in the elder brother at 8 years of age, had hepatomegaly present and splenomegaly present. And when we did, because she had bleeding from her mouth, we did an upper GI endoscopy in this patient and we could see grade 3 varices present. We asked for a ceruloplasmin level which was high, copper excretion was high, and then a slit lamp examination was done which showed that there were KF rings present. So this was a case of Wilson's disease which was leading to a anemia, but not a pure hematological disease. So how would you work up a case who has pallor and has hepatosplenomegaly? You look at the presentation. Is this acute versus chronic? Is there other features present like fever or bleeding, or is this just severe anemia? If it's severe anemia, look at infections. If there's fever, look at infections or think of malignancies in these patients. However, if there's bleeding, then that looks more like an infiltrative disorder that may be present. If this is chronic infection, then you look at storage disorders, you look at neoplasms like CML or JMML in these patients, or you think of other immune causes like a SOGIA in these patients as well. I want to end by talking about bone marrow transplants in these of our patients. So bone marrow transplant is a way by which we can replace the stem cells that are the building cells for all our blood cells as well. So when we are doing a transplant, we are transplanting the stem cells of our patients. The first step that is most important for doing a stem cell transplant is to do an HLA typing for this patient. Once we have an HLA match, then we can offer them the transplant for these patients. HLA typing can generally be done by two methods. One is called a low resolution typing, which is used for sibling donors, and the other is a high resolution typing, which is the typing that we would prefer whenever we're looking for matched unrelated donors or we are considering a half matched or haploidentical transplant. The easier way out is to ask for a high resolution typing for the patient, because that then can be used for the others. If you don't have a match sibling, you can use the same HLA typing for asking for a mud search or asking for a haploidentical transplant. Transplants are generally classified as two types. Autologous, when we are thinking of using the patient's own stem cells to give them higher chemotherapy. So we collect the stem cells, keep them, cryopreserve them, give the patient high dose chemotherapy, and then to avoid the side effects of the chemotherapy, we return the stem cells back to them so that they do not have a very prolonged period of neutropenia present. The more common type of transplants that we do in our pediatric populations are the allogenic transplants, where we are using a donor. This donor may be related or maybe an unrelated donor, and the intention is to replace the defective stem cells of the patient itself. There are different ways that this can be done, but this is the more common type, and this is the type that we are offering for patients with thalassemia or with relapsed malignancies in these patients. We are commonly using a drug called ATG in our patients, and the reason why we wanted to talk about a little bit of ATG in today's talk is that because it is used as a conditioning regimen to prevent GVHD in our patients, we use this medication, but it does lead to a lot of a lot of immunosuppression and may increase the risk of infections post transplant. Now, because these children go back to the parent physician at the end of the transplant period, we need you to know that if this child has received ATG, their child may be susceptible to getting some viral reactivations which may occur even more than 3 months down the line. The usual dose that we have generally been using is about 2.5 milligrams per kg per day. We generally use it prior to the transplant, so day -4 to -2 or -1 in these patients. And again, you have to remember that the patients who've received ATG may have viral reactivations later after the transplant as well. I will like to conclude today's talk by a few take-home messages. One is that nutritional iron deficiency is never responsible for anemia in term infants prior to 6 months of age. Preterm infants will not get a nutritional deficiency prior to doubling of their birth weight. So think about nutritional causes generally after 6 months. Anything that is detected between 3 to 6 months is either a congenital disorder of the hemoglobin synthesis or structure in these patients. A good history taking will give you very good clues to diagnosis. You can reduce the cost of investigations in these tests. But please remember to send off the blood test before a blood transfusion is done. Iron deficiency anemia seldom will need a blood transfusion or parenteral therapy in children. It is generally a very rare cause that requires IV iron therapy. But please be alert that every child with anemia and or pancytopenia may have a leukemia lurking in these patients. So if you are thinking or if you have any suspicion for leukemia, please try and avoid the use of steroids and investigate completely to rule out malignancies in these patients. 15th of February is International Childhood Cancer Awareness Day. And we need your help in this because we would like to cure pediatric cancers and improve survivals in all our patients. And this can only happen if we have your support and the supportive care that you can offer to these patients at your centers when they come back to you. Thank you so much for the attention that you've given me today.
Yeah, thank you very much, madam. We have only one question I can see. Can we diagnose beta thalassemia by newborn screening? What will be the pattern?
So beta thalassemia cannot be diagnosed by newborn screening because the HbF levels are expected to be high at newborn. Unless there is a history of having thalassemia in the family, it is very rare to pick up thalassemia in a newborn patient. If you're suspecting thalassemia in these patients, then you need to ask for an HB electrophoresis of the parents because they should be thalassemia traits. And that's the way. And if you're really convinced that this is thalassemia, ask for genetic mutations for the patient. But just an electrophoresis before 6 months of age is not diagnostic.
Okay, thank you. That was the only question in the question box. Thank you very much, Dr. Ruchira Misra. We have, in a very short time, you have covered a long list of hematological disorders, including the malignancy. Thank you very much.
Thank you, sir, for having me here today. It's an honor to be able to speak to such a big gathering.
Yeah, thank you. Thank you. Friends, now from pediatric, we move on to diabetes, and we have two more speakers to speak on diabetes. The first is Dr. Altamash Sheikh. Dr. Altamash is not new to IMA. He has given many lectures previously also on this for this IMA crowd. Altamash has already shared his screen. I'll just read out his biodata. Dr. Altamash Sheikh is a consultant endocrinologist, diabetologist, and metabolic physician at Saifi Hospital. He's a visiting consultant at Masina Pensali Khan and LTMG Sion Hospital. He is a state ranker for MBBS from Rajiv Gandhi University of Health and Sciences. He then did DNB in General Medicine from BPT Hospital and DNB again in endocrinology from PD Hinduja Hospital. He has actively participated at national and international workshops, training programs, and conferences to enhance his knowledge and skills, and is also involved in teaching medical students, family physicians, and paramedical staff. He regularly organizes diabetes education programs and actively involved in setting up the diabetic clinic. He has many co-authored articles and is also reviewer in peer-reviewed journals and presentations and talks at various national and international scientific conferences. Today, Dr. Altamash will be speaking on rational use of anti-diabetic agents in remote consultations. Over to Dr. Altamash.
Thank you, sir. Good morning, everybody. And I think I'll be very quick looking at the time. I think I was given an 11:30 to 12 o'clock slot. So
Yeah.
let's do justice to time and help IMA in concluding the program. So I would expect it to be a little more of an interactive rather than I just speaking about the slides. So kindly keep your questions ready and we'll take you through this particular talk on unlocking the doors to the new normal about how do you check these remote consultations. Although we always have been speaking about that, which is that right drug that we can start to the patient on our phone or just on a phone consultation. But however, the pandemic thing has really brought us a lot of light in our clinical practices. So there's some specific factors related to the drug, whether it's patient specific or drug specific, and we got to take all these factors as shown over here and put it and individualize it to the patient preference, patient's renal cardiac status, ease of use, complexity of regimen, of course, looking at the patient's HbA1c weight and efficacy in reducing the hyperglycemia. Yes. Is there any question that you would want to ask on safety use of OA trays in a remote consultation or in an online consultation? I'll be happy to answer on that. Okay. Thank you so much, doctor. And take care.
Yeah. Okay. Thanks a lot, Dr. Altamash.
Thank you. Thank you.
Yeah. Friends, there was a bit break in the network issue. Okay, I will continue with the next speaker, and that is Dr. Nasir Fulara. I'll just share introduction slide of Dr. Fulara. Dr. Nasir Fulara is a consultant senior physician, cardiologist, and diabetologist attached to Jaslok Hospital. He is a visiting consultant at Bichkandi, Saifi, and Bokad Hospital, Mumbai. He did his MBBS and MD General Medicine from Grand Medical College and Sir JJ Group of Hospitals, Mumbai. He has taken specialty experience at Houston, USA for cardiology, Dusseldorf, Germany for diabetes, and London, UK for general medicine. He has been rewarded with numerous awards like Mother India International Award, Commemorative Medal of Honor, Best Physician Rajiv Gandhi Gold Medal Award, Vikas Ratna Award, etc. He has been a speaker at various international and national forums like ADA, ESD, AHA, IDF, ESC, RSS, DI, EPICON, IMA, etc. He has authored many books, presented several papers, and has many research and publications to his credit. Dr. Nasir Fulara will be talking to us on agliptin progress, how to design a drug with patient needs in mind. Over to Dr. Fulara. Sir, good afternoon.
Good afternoon. Good afternoon. How
Yeah.
Sorry.
Yeah. We are finished with your introduction.
Yeah.
You can just share your screen, sir.
Okay. Thank you very much. Good noon to everybody.
Yeah.
Thank you very much, Dr. Anil, for the introduction. And today we will try to make the discussion brief as well as very interesting. And sometimes we do enjoy going back, when we reach a destination or about to reach a destination, we always are more eager to understand the journey that we started, what we call the history, and then what problems came on the way and how we have achieved it. But before that, we have to have a vision also that what we want. And that's why nowadays we talk about designers, dresses, designers, jewelry, designers, shoes, and similarly the medical fraternity was no less. They also wanted a designed sort of a molecule, especially with regard to the diabetes. The expectations were increasing from a medical fraternity toward the researchers and toward the pharma companies. Initially, what we wanted was the control of fasting, PP, HbA1c. Then came glucose variability from the triangle to the quadrant to the pentant, and now we have the ominous octet, 8 pathophysiological defects that we wanted to be controlled by a single molecule. And that's how the research started. Grateful and thankful to MSD, which took up this challenge, and plus other companies also did take up the challenge. But to first to arrive to the destination who took us to was MSD. So just to go through this hurriedly, I will be going through the slides also. And at the in between our science, the molecule also will start. So a glimpse progress how to design a drug with the patient needs. Now, if you see over the last 100 years, our understanding of type 2 diabetes, mellitus pathology and therapeutics have increased greatly and associated with the complexity. If you see 1920, we only knew that diabetes is nothing but insulin deficiency. So we started giving insulin. But in 1950, we came to know that it is not only the deficiency of insulin, but also secreto defect. So we started having the sulfonylureas, that is the secretogogue. So the insulin was secreted out also, rather than only giving from outside. As we reached 1970, we expectations our increase, and we found that insulin deficiency, yes, there is also a secretagogue molecule also we want, but at the same time we are now facing insulin resistance. So then the PPAR agonist molecules came in, like the metformin and the pioglitazone. As we progressed to 1990, we knew insulin deficiency, we were confident in secretagogue, we become more insulin resistance with coming out this PPAR agonist and metformin molecules also. But by 2000, along with these four, we also came to know that there is some defect called alpha cell defect, alpha cell dysfunction. And that's how the incretins came into the picture. But it was in 2010 that along with the four, the fifth one also came. That is, can we throw out this excess sugar through other ways or other means, because our horse, the pancreas, is getting tired. So then came the glycosuric agents called SGLT2 inhibitors. We don't know beyond today, beyond that until today, and more years to come, more steps, more combination, more researchers, more of our understanding of the disease, more expectation, and definitely more molecules. Are they going to come or not? The time will decide. Next. This. Now we come to the true objective. The true objective of diabetes management never really changed. You know, that's what I said, that addressing the needs of the patient was very important. Over time, we learned that more about the needs, that is ominous octet pathophysiological defect. See, more and more we learned the needs, we knew the core defects. That's why we were trying to develop, we were expecting the pharma to develop an agent that would address them all, but we wanted them to be addressed safely. That's how comes the our gliptins and incretin science. Story begins in the early 1900s. We had no real therapy for diabetes at that time. It was more than 50 years before even the term type 1 and type 2 diabetes were coined by Philip Hughes and Jones while working in Jamaica in 1955. So it was the birth of type 1 and type 2, the coins that were given were in 1955 in Jamaica by our great Philip Hughes Jones. An effective treatment for diabetes was needed in the early 19th. This search gave birth to the entire field of endocrinology. So it was, the word endocrinology was given the birth in 1902. So that is where also the birth of science took place. And if you see these slides, you come to know that the incretin is intestinal, cret means secretion, E means insulin. So intestinal secretion of insulin in 1902, Bayliss and Sterling used gut extract to stimulate the pancreatic secretions. It was 1905 that secretin was recognized as an intestinal hormone. It was 1906 the treatment of diabetes was given with the acid of duodenal mucous membrane. And 1909, Nicola Pende proposed the term endocrinology. So from 1902 to 1909, the word endocrinology from the birth to the adulthood to the establishment of this terminology called endocrinology took place. Then come the 1923. These two great scientists, OM and Mimas, they found that this secretin or creatine, they are stronger in hyperglycemia. 1930, they were labeled from secretin to incretin. 1964, then they become more and they showed the effect of incretin effect, how important it is. So it's been a long journey that the incretin hormones have come right from 1971 to 78 to 1985. And of all this, of course, we found it that insulinotropic action, how good they are in hyperglycemia, and the effect of all these so-called incretin hormones in the hyperglycemia with GLP-1 and GIP. But of so many, only two incretin hormones were found to be most important. The important were found to be were only GIP and GLP-1. GIP, the first incretin hormone to be identified, initially it was named as gastric inhibitory polypeptide, but later on it was more understood, more understanding of this molecule, changed the name to glucose dependent insulinotropic polypeptide. And remember, it is secreted from the case of the small intestine. But the GLP-1, that is glucagon-like peptide, remained the same name. Second incretin hormone discovered following the cloning and sequencing of these pro-glucagon genes and complementary DNA. GLP is released from intestinal L cells. So GLP from L cells and GIP from K cells. Now, the journey, how GLP-1 is quick comparison will do. We of course use more of GLP-1 RA rather than GAP, but GAP is also important. More potential insulinotropic effect is there with GLP-1, but higher contribution to incretin effect is seen by GIP. Effect level and action is seen with the GLP-1, and GIP is reduce the action very fast, and level may be, there is an increased level, but the action gets reduced very fast. Both GLP and GIP are important for the incretin effect. Incretin defect in type 2 diabetes is more due to the deficiency of GIP. Remember that, though GLP-1 RA we are giving, but it is because of the GIP that is the effect is seen. So that's why in hyperglycemia, to increase the insulin synthesis and secretion, GLP-RA we use. And to reduce the glucagon suppression, we use GLP-RA. But GIP increase the insulin secretion as GLP-RA. But here, the difference between the GLP-1 and GIP is that there is increase in glucagon secretion. So in creatine, that's why they are very neutral to hypoglycemia, because the dual effect of glucagon secretion and glucagon suppression and glucagon secretion in where there is hypoglycemia taking place. So the glucagon secretion is increased to compensate the hypoglycemia, which is a GIP effect. That's why what we want is a predominant GLP-1 as well as GIP-1 to a lesser extent is ideal, the desirable that we would expect from a secretin. Now comes the did we need an agent to increase the insulin secretion? Yes, of course we needed an agent. And by the 1980s, we already established insulin-based therapies and effective sulfonylureas, which could extract the insulin made by the beta cell. We were through that. However, patients either had failing beta cells, that is the horse getting tired, or the therapies were extracting excess insulin and more than required, and that's why many times the sulfonylurea started giving more and more incidence of hypoglycemia, and sometimes in presence of ischemic heart disease or cardiac disease, it becomes very fatal. So we needed agent that could help the beta cells make more insulin only when more insulin was needed. That is, in presence of glucose only, we needed the action of the insulin secretion rather than irrespective of the glucose presence. So that was again one more our expectation, which increased from our medical fraternity side. Like sulfonylureas, incretins increase the insulin secretion, but they also increase insulin production also, and that is that in a glucose dependent manner. Now this is what we uh, uh, in a glucose dependent manner was the DPP4, our gliptins and cretins that we were desiring it, that it should increase it only in presence of glucose presence only. So in cretins, stuff, like sulfonylureas production that just encouraging to manage. That's why they were brought into the picture. Possibilities and challenges. Incretin infusion, more precisely GLP-1 infusion, looked like a possible solution, but continuous GLP-1 infusion was not feasible. Then what to do? Can we increase the half-life of GLP-1? Can we prevent this breakdown? Can we get an oral agent so that more action of GLP-1 remains in the body in presence of glucose? It can make the insulin more secreted and more effective. So came how GLP-1 is getting breakdown. They found out that it is the DPP4 enzyme, which is the key factor, and that is breaking the GLP-1. We wanted DPP4 enzyme inhibitor, so that GLP-1 RA, that is what we call it, the DPP4 inhibitors, they will make the GLP-1 go in the circulation for a longer effect, and that's how we get the more insulinotropic effect also. So what is DPP4 enzyme? Is a serine exopeptidase. It is in 1966, it was first reported by our scientist Hobbs of Harvey. And it was in 1993 that Mendelian DPP4 enzyme breakdown incretin was established by him. It was in 1993, understanding of DPP4 enzyme was found. This is a very interesting slide, that this is an animal called Gila monster, and it can remain without eating, without food for quite long time. And they found out that how come it is possible. They found from the saliva that Gila's saliva is the reason that Gila monster, after long periods of not eating, is able to slow down its metabolism and maintain constant blood sugar level without affecting its health. So it was found that the saliva of Gila monster, there was a DPP4 enzyme, exenerated 4 was found to be a GLP-1 RA receptor agonist. So this is more and more GLP was produced by this so-called saliva. So saliva, what happened to by the saliva? Stimulate the pancreas to secrete the insulin. That is exenate 4 discovered from saliva. Exenate 4 similar to both structure and functioning of GLP-1, but exenate 4 remains active for hours together. So we wanted our GLP-1 also not to be broken down, and also we wanted to be effective for a longer period, suggesting that if long acting we could get it, effective diabetic treatment can be achieved. Now that is how preventing the breakdown was the first target of GLP-1 by getting the DPP4 enzyme inhibitor, and that's how the endogenous damage to GLP-1 was lost, and it lasted the effect longer. But it was, as I said, in 1992 that the proposed use of GLP-1 for treating it took more than 3 years by the Deccan, Knock and Holt to propose DPP4 inhibitors. So though it was in 1992, but it was in 1995 that DPP4 inhibitors came into the market for the management of diabetes mellitus. The very first time, of course, it had to go through a lot of studies, trials, randomized control, and it was in 1995 and 1998 that the DPP4 enzyme inhibitors came into the market. What were the early consideration? What they expected from a DPP4 enzyme inhibition? They wanted that inhibition should be meaningful. At least 80 to 90% should be inhibition. Substrate like inhibitors, they wanted low potency, but stability wise also they were very we wanted stable also. Multiple dose, they didn't want. They wanted a long lasting OD dosage. And also their expectations were the ideal route. Inject, no, they wanted the expectation was to get an oral route. So optimal efficacy, prolonged incretin effect, half-life, both potent and prolonged DPP4 inhibition was desirable. This was the expectation. More than 100-fold selectivity they wanted over the DASH, and the challenges were identified later after a few animal studies. So that's why it took about couple of years to come back into the market, and that's how the first generation gliptins came, second generation of gliptins came, and then came the third generation of the gliptin. The all gliptins in the first generation with DP4 selectivity were found to be less than 100-fold, but in second generation it became better with the dash mean DPP4 activity and subtract homologue. So they found that selectivity was more than 100-fold. So one achievement was done. Now was the durability. The third generation with more than 100% selectivity, inhibition was also more than 90%, which went on for more than almost 24 hours. So generations of DPP4 inhibitors not based on chronology of the development, but based on desirable, let me stress the word desirable, pharmacodynamic properties, which we wanted it to be 100-fold action and almost 24-hour action. So early experience, what were the early experience? Some DPP4 inhibitors have several effects on immune cells. Unfortunately, that's why malignancy, carcinogenic effect, immunogenic effect were seen, which we didn't want it. And it was because of the FAP. So more understanding, MSD in 1999 initiated its DPP4 program at the time when at least 2 DPP4 were already in clinical trials. And this was called the probio drug. And this is some early, this is the molecule probio was P32/98 that MSD came out. And of course, it was also, there were other molecules which were there from the Novartis also. And there are more and more understanding and studies were going on early human cells, where in animal models, and they found that the P32/98 molecule experience of that is the probio drug of MSD, well tolerated it was, but animal models showed severe toxicities. And that's how in 2001, unfortunately, because of this severe toxicity, development is continued in early molecules. You see, today the most successful DPP4 CETA also had a lot of problems in getting the approval done, but the company never lost the hope. It went on correcting its defects. It went on meeting the expectations of the regulatory authorities, and also it went on delivering the expectations what was from a clinician to control a diabetes with the list of the side effects and complications, and more of the cardioprotective drug. So that's how the comes to why this drug fail. It failed because of the toxicity over the dash inhibition. So that was the only which they didn't want was the dash inhibition. That is how the molecule again the next DPP4 inhibitor had to be designed in the lab step by step. Multiple hits and misses were in, and the final goal was set to identify an inhibitor with 100-fold activity or more than 1,000-fold activity now, and window for DPP4 inhibition over the dash. So they didn't want the dash effect, but more and more effect to last longer. So final screening hits at MSD Research Lab. Only 3 leads, and finally what they saw was the piperazine, relatively low on potency, phenylalanine derivatives very potent, but at very poor bioavailability. So that's how they proceeded. Next, in January 2002, MSD finally got the sitagliptin. This was potent and safe in terms of DASH-related toxicity, and sitagliptin was approved, and that is how the sita was approved for humans use in 2006, barely 4 years after it was synthesized in the lab. It was the first DPP4 inhibitors approved for making a marketing anywhere in the world, first in Mexico. It was the first one which came out in the world, and from then on, sitagliptin has remained number 1, and it has never disappointed us from any of the better and effects, and it is regarded as the golden molecule to be compared with any other DPP-4 inhibitors. It's a gold standard molecule, I would say. And as the years pass, almost 15 years, every year it has shown its more and more better effect, multiple effect, pleiotropic effect, and it's like I always say, old songs never die. So sitagliptin is like that, which keep on hearing them every conference we go abroad. We keep on hearing more and more better effect and newer things that have been shown, the desirable effect that has been seen in the sitagliptin. So that is how the therapeutic wish list for the 2000 was achieved. Question mark? Yes. An effective agent for all type 2 diabetes patients. Most. A well-tolerated agent addressing and correcting key pathophysiological defects. Achieve a target, maintain the target as long as possible. Simple dosage OD can be used safely in various comorbid conditions, yes, and can be combined with other common medications, yes. Now that is how the sitagliptin in 2000 came, and with meeting the expectations of all of us. What were the other agents at that time that we were having in 2000? Were they all also safer and better as per expectation? Unfortunately, no. They had their own unique challenges also. Metformin developed from French lilac plant, found to be unfortunately concerns in renal impairment. You can't give. Risk of developing lactic acidosis was seen, and in some required up titration required, and did not address all or pathophysiological defects to be taken care of. Sulfonylurea discovered from sulfonamide antibiotics. We all know that. Unfortunately, hypoglycemia was the increased risk, and as the patient came near to the target, the side effect was pronounced more. All concerns of CV hazards and not so positive effect on beta cells stress markers, because it made our horse very tired. The beta cells were getting very tired because the continuous secretion was going on of insulin. Even there was no requirement of insulin in the body. Then came our PPAR agonist, that is thiazolidinediones, initially developed as an agent for dyslipidemia. This is what they were developed. In fact, postprandial hypertriglyceridemia was the earliest sign that still regarded as for an early diabetes, that a pre-diabetic period. If somebody has postprandial hypertriglyceridemia, be careful. He's a candidate for long for the diabetes. So effective sensitizer, it was found like metformin, emerging concerns of fluid retention. 3 side effects, unfortunately, has given a setback to this molecule. One is the fluid retention. That's why in cardiac, cases, you can't give this. And if at all you want to give, because it works wonders with regard to the IHD, but you got to be very careful, very small dose. In India, 7.5 to 15 milligram maximum. But if it is LVEF is already compromised, please do not use it. If LVEF is normal and atherosclerosis is the main concern, this is again a wonderful molecule, but be vigilant, because the fluid retention, heart failures can be precipitated if not taken care of. Fractures and bladder cancers are also a point of, so whenever there is a enlarged prostate, you've got to be careful to use this drug in older age group, and older age group, especially ladies, also fractures are more pronounced. So again, we are going to be careful in using this molecule in these 3 conditions where the concerns are there more and more. The effect of CETA in humans, very high oral bioavailabilities, minimal metabolized in the body, more than 80% excreted unchanged through the urine, the rest mostly hydrolyzed by DPP-4 enzyme. Post-administration, of course, a good effect of almost 24 hours seen, and 2-fold increase in C of GLP-1 production. No clinically relevant drug-to-drug interaction, and also with the food, also it can be given anytime. So this is how the 2000 gluten they turned out to be a better, efficacy-wise, well-tolerated, address correct some of the key pathological defects, durable, improve compliance, can be used safely in various comorbid conditions, minimal drug interactions, and yes, there we have that these DPP-4 inhibitors as far as the beta cell function is concerned, directly target the beta cell function. SGLT2, there is no effect on the beta cell. Sulfonylurea improves beta cell function, but the effect is long lasting, giving rise to hypoglycemia. What about the glucagon dysregulation? Regulates the glucagon secretion. Whereas here SGLT2 increase the glucagon. That's why they have a compensatory effect in hypoglycemia, not direct effect of sulfonylurea. Hepatic glucose production, which is the cause of the hyperglycemia, inhibits hepatic glucose release. That's how it is. DPP4 is again pathophysiological defense is taken care of. Here it is hepatic glucose production is increased as a response to the renal glycosuria. Again, one can consider this as a compensatory phenomenon for in hypoglycemia, whereas the sulfonylurea unfortunately has no direct effect. Insulin resistance improves insulin sensitivity, whereas there is no direct effect in both. DP4 enzymatic activity inhibition attenuates endothelial. Now, this is very, very important. Endothelial dysfunction, inflammation, and atherosclerotic process. That's why in our pandemic, because of his endothelial dysfunction effect and anti-inflammatory effect, this molecule was kept going on and never even omitted out in diabetic of COVID-19 period. And SGLT2 reduces the renal, this is SGLT2 upregulation and renal glycosuria, reduces renal glycosuria secondary to glycemic control. Whereas the SGLT2, of course, increases the main effect is throwing out the sugar through the urine. Now, these are the 6 pathophysiological defects you find that, and the 7th one, which was the indirect effect of reducing the glycosuria, was also taken care of. Only thing which was not taken care was the appetite center, that is the neuro inhibitory effect on the appetite, satiety, which we call it at the. But that is also it's a neutral. It doesn't increase the appetite, and it is weight neutral also. So that is how, which we see in sulfonylurea, increase in weight is a big concern. I'm not talking about the newer sulfonylureas, which are of course as safe as any other drug. Now, effects of combining metformin with sitagliptin, it is like a sonepe suhaga, a feather in the cap, a more reward, combination, rewarding combination. If you see this, especially HbA1c, FPG, fasting proinsulin, HOMA beta, HOMA IR, all combination with SITA, with MET, excellent results you see when only metformin is given over there. So again, a very good combination with metformin potentiated. It is more of a, metformin was always regarded and is regarded as a kingmaker. I would say the sitagliptin is a kingmaker. And now I consider as when it is combined with any molecule, the better effect is seen, more potentiate the effect of the primary molecule also. So it is friendly with all the combinations. Why gliptins are relevant today efficacy-wise? Number one, efficacy no less than any other agent. 2, efficacy across various age groups it is seen, and efficacy similar across all CKD stages. This is something which we are concerned. One is the CV safety and the renal safety. Here you have both the safety over here. That's why we have a TCOS trial, which they have also shown that the CV safety wise, the sitagliptin is very, very safe. Time came when with the SGLT2, DP4 inhibitors were going down in the minds of the consultants and the scientists when the sitagliptin, the MSD, came with the TCOS trial. It gave a boost up of this in the same molecule with regard to the CV safety, and there was again a good euphoric feeling over the clinician's mind that here we have one molecule to achieve the target and give a better life to the patient of diabetes. Now, in impact of baseline HbA1c on the efficacy of the SGLT2 and DPP4. Now, you see, if you see 1, 2, and 3. When I see the previous slide, we find that all this, the more uncontrolled, more better effect. More combined with the SGLT2 and of course with the DPP4 inhibitors, more better effect is seen. So it is a complementary effect that you see with the DPP4 inhibitors, not only with the metformin, but also with the SGLT2. more uncontrolled it is HbA1c, more reduction of the HbA1c is seen. So again, I said it is a very good kingmaker and effective add-on to metformin. Are they durable? Now, this is also one slide if you see on the right side. That is, as the time goes, the glycemic control improved initially very much with the sulfonylurea, but following the addition with metformin also it increased, but the deterioration starts as early after 6 months. You start finding that after 6 months, the same molecule, you're not getting the expected or desirable HbA1c control. So this is what is, worrying us. And every time when the HbA1c, so this is because of the tiredness of the beta cells. Sulfonylureas continuously keep on excreting the insulin from the beta cell. So after metformin, should we give sulfonylurea or gliptin when efficacy is the only consideration? In short term, head-to-head studies showed sitagliptin is as effective as sulfonylureas. Over long-term multiple studies, it suggested that sitagliptin is more durable also as compared to the sulfonylurea. So these two studies have confirmed that it is the DPP-4 inhibitor sitagliptin which should be preferred over to the sulfonylurea in the management of diabetes. This is the study over 7 years, and that is how this efficacy-wise we find that the sulfonylurea efficacy may be less in long-standing diabetes or when functional mass of the beta cell comes down, it becomes low. Sulfonylurea usually need dosage up titration for treatment and maintenance after a period of 6 months. And sulfonylurea used with insulin is of course not desirable because both are potent hypoglycemic agents. So hypoglycemia is very much pronounced, which can lead to the death also. So it's a deadly combination, sulfonylureas and insulin. But yes, as and when you find that there is a lot of uncontrolled hyperglycemia, then one can use, but one has to be very, very vigilant. You can't just leave the patient on their own. So now what about the CKD? What about the role of oral anti-diabetic drugs? And we find that what our concerns is efficacy consideration we want. We want safety consideration, and we want usage restriction. Also, we would like to keep it in the back of our mind. If you see metformin, sulfonylurea, and pioglitazone, gliptins, and the last one is the SGLT2 inhibitors. Now, with regard to that, if you see the metformin, we all have discussed sulfonylurea, pioglitazone, we all have discussed. As far as the gliptins is concerned, it is effect across the spectrum of all CKD. Of course, the dose adjustment has to be done. Safety consideration, none, not to worry with the inhibitor. Restriction can be used on all stages of CKD, except in linagliptin, which does not require any alteration of the dosage. The rest of the molecules, especially sitagliptin, from 100 to 50 kD on dialysis, 25 milligram can be used over there. Now, if you see this in that way, gliptins score over and use with insulin greater experience longer with less hypoglycemia. If at all is the patient is insulin dependent, then also you can add on your DPP-4. DPP-4 has a very unique feature. One is prevent the apoptosis. Apoptosis means beta cell destruction it prevents. And number two, in animal module, there is effect seen is a regeneration of the beta cell. That's why people who are undergoing in the Western countries, the beta cell transplant, they are given DPP-4 inhibitors because of these two great effect of DPP-4 inhibitors. That is the preventing of apoptosis, means destruction of the beta cells, and also regeneration of the beta cells. So the beta islet cell which are transplanted, they don't undergo degeneration or the destruction. So that is how it is with insulin. This, when you are combining with DPP-4, not only the etiology that we discussed, but these two great things of apoptosis and regeneration, we are also getting in the future the quality of life to the diabetic with the list of the complications that we may be offering. Maybe a better control with the almost, so in the long run, a viability of the beta cell will be lasting longer period. So this is how usage pattern, ease of use. We find that with regard to the DP or no regard to time of meal, except short-acting gliptins, you can give it with the food. There is no problem as far as that thing is concerned. Safety wise, we all have discussed and we find that none, as far as the consideration of safety wise, you call contraindications are none. Contraindication we have in every list excepting sulfonylurea, but then sulfonylureas we all discussed. New sulfonylureas are much better, including glyclazide and glimepiride. They have none contraindication. Box warning, of course, we have box warning with regard to these two sulfonylureas, of course, no, but otherwise metformin, PIO, SGLT2, especially the canagliflozin, we have increased risk of lower limb amputation. And this is the main thing that the gangrene, that is what it is. And DPP-4s, of course, have none with regard to the box warning also. So as far as the safety of gliptins as compared to the SGOAD, if you find that when we concentrate only on DPP-4 inhibitors, increase the risk of hypoglycemia. If you use it with sulfonylurea and insulin, so you've got to be careful. With regard to the other DPP-4, Sexa unfortunately precipitates heart failure, Vilda, hepatic impairment, teneligliptin is causing QT prolongation. You've got to be very careful, but it is not approved FDA, and you has to be very careful with regard to the kidney. Also, there are no trials over there. So DPP-4, we want DPP-4 to be very specifically controlled. We don't want DPP-8, neither we desire DPP-9 and leave aside fibroblast activating protein, FAP, which is the responsible for microgenesis, progression of the tumors and wound healing and blood clotting. So we want very specific DPP-4 inhibitors. That's why more than 1,000-fold specificity we want it. And because DPP-4 has the immunity coming in the way, spermatogenesis, fertility-wise, so we don't want the other, and this is how our focus is to control the DPP-4 only, specified wise. Selectivity profile is very important. That is of DPP-4. That's what we just now saw the slide. And we find sitagliptin, 100-fold selectivity, yes, over the DP8 and 9. And 100-fold selectivity of DPP-4 over FAP, very, very important. And selectivity is, in short, is very high with sitagliptin as compared to the DPP-4 inhibitors. So that is how the snapshot, if you see cardiovascular outcome trial with DPP-4, TCOS is with sitagliptin. This is the trial which brought back DPP-4 inhibitors. Of course, Seca, we have Sever, Carmelina, Lina, again a good trial, very good indication. But accepting we're going to be careful on non-fatal MI. Otherwise, wonderful molecule can be combined with any molecule and without getting concerned with the CKD also. Carolina showed confidence. In fact, it was for more of a Lina, but glimepiride became more benefited. And again, the safety of glimepiride was also proved with regard to the CKD. And of course, the EMPIRIC trial. The three advantages of EMPIRIC came was the incidence of 3-point S was reduced, CV death was reduced, because the mortality was reduced. But otherwise, as far as the DPP-4 is concerned, the TCOS stands out in its effect. And if you see all throughout, all the, whether it is CV death, it is non-inferior, mass is non-inferior, excellent control of HbA1c, non-fatal stroke is almost not seen, non-fatal MI, peripheral arterial disease, and of course, non-inferior to the heart failure also. So this is a safety-wise an excellent molecule, and this is how we find it, that drug interaction with gliptins also are with DPP-4 are very, very less, very, very safe. Only metformin, sitagliptin minimally metabolized through the hepatobility and sita, and all these no clinically relevant drug-to-drug interaction. Are gliptins safer than other agents? Yes, because gliptins, they have none of this effect of hypo, weight gain, GI distance, and genital mycotic infection. Nothing is there. So summarizing, sitagliptin is the first anti-diabetic drug designed in the laboratory with patients' needs in mind. It is the designer's molecule for the clinicians. Gliptins, largely sitagliptin in particular, answers to the clinicians call of managing type 2 diabetes patient in the right way, effective across all T2DM spectrum, no specific known subtype of adult T2DM where it is not effective, it's effective at all age group, tolerability wise also excellent, durability wise, safety wise, efficacy wise, comorbidity wise, whether it is elderly or whether it is a working professional, can be combined with all the diabetic agents, establish cause CV safety profile. Thank you very much, Dr. Anil, and all of you and MSD for being patient and hearing me. Thank you.
Thank you very much, Dr. Fulara. It was an excellent presentation, and you have solved all the questions in our mind about gliptins. Thanks a lot.
Thank you.
Friends, are there any questions? Sir, should we redefine value of HbA1c for normal or pre-diabetic? I don't know what it is.
Younger age, the desirable is of course 6.5. If it is a diabetic, we try to keep him at 6.5. But if you really want, the stricter 5.4 to 6.5 is no diabetes. But if he's already a diabetes and young, we don't allow more than 6.5. So tight control is desirable. But as far as the senior citizens are concerned, from 7 to 7.5. Otherwise, middle age group 7. Hypoglycemia to be avoided as far as possible.
Okay. Thank you very much, sir. There are no other questions. And here we end today's CME. And I request Dr. Sachin Patharkar to give the vote of thanks. Sachin.
Hello. Good afternoon, all. Good afternoon, all. I would like to thank all our speakers for today's webinar. Dr. Shiv Prakash Krishna Naik, Dr. Bharat Dalvi, Dr. Ruchira Mishra, Dr. Altama Sheikh has not delivered, but he was a speaker for the day. Dr. Nasir Fulara. I also thank our knowledge partners for the day. Sir HN Reliance Foundation Hospital, Sanofi Empowering Life, MSD Pharmaceuticals Limited, Mr. Dipen Mehta and Mr. Siddharth Linge from DigiShield, who have given us a platform for this webinar and handle all technical details. At the same time, I also thank our observer for the day and all the delegates for participating in this webinar to make it a grand success. Thank you very much. Thank you very much all.
Thank you all. Thank you, Fulara sir. Thank you,
Thank
Jitesh.
you. Thank you very much.